in this particular session. The first talk will be on a food allergy. The second lecture is actually a twin lecture series about artificial. Request Dr. Payodhi Dhar to kindly invite the speaker and start the session.
Having us today here. As I understand that it's post-lunch session and all are in Sunday lunch, all are a little bit timid, and I would like to invite Dr. Niharanjan Mishra, a renowned pediatrician from AIIMS Kalyani, to deliver his talk, please. Thank you.
So, good afternoon everyone. Thanks to the organizing committee for giving me a chance to deliver a topic on recent innovation and food allergy in pediatric practice. And I am also grateful that I came to know Dr. Karthik is here, who is my teacher's son. So after a long time we were able to meet each other. So without wasting much time, I am going to present a slide. So the learning objective for today's session will be more or less you all know about the food allergy. What is food allergy, present burden across the globe in India, then what is immunotherapy in food allergy, and what is the final take-home message we can take home with us today after this topic. So food allergy is something like it is an immunological reaction to certain food which produce repeatedly and exposure to the same food. And as you all know, these are the overall system how the food allergy works. Once the food enters the epithelium, there is damage, there is cascades of immunological phenomena, then there is release of the allergen, the release of the antibody and histamine. So in this way, the allergy reaction occurs. And what is immune tolerance? Immune tolerance means by gradually exposing the same food in a low to level to gradual level, there will be the immunological cascade in the direction of Treg cells, regulatory T cells. And then there will be release of IL-10 and then B regulatory cell, then plasma cell, and this will neutralize the effect of the already mast cell and basophils. So gradually, when you introduce some food in a graduated, in a standard protocolized wise manner, in a long term, you will get a tolerance. And that is the aim of immunotherapy, by which if a tolerance occurs by 15 to 20 years in natural, we are making the tolerance in mostly in 5 to 6 years. So this time gap is important. Then these are the most common 8 foods which causes allergy in pediatrics. There are lots of foods are there, but out of these 8 foods are very important. And out of peanut, cow milk and egg, these 3 are much more important. There are lots of articles on these 3 topics, what to do, what not to do, how to proceed. This is the data, overall burden of food allergy across the globe. If you see, the red regions are the high incidence areas, and the India, we are lucky that India having no data, it doesn't mean we don't have the food allergy. It may be like that, there is scarcity of data or unpublished literature. However, whatever may the reason, this we are lucky enough, till now we are not having so much of burden in India. But as my teacher Dr. Nagaraju sir told me, Nihar, one day will come around 30-40 years after, you will get a lots of food allergy cases because of the epigenetic text, which I will tell you later in the coming slides. Why it is less in among Indians? There are some associations, no evidence. One is the humidity, one is the consumption of the vegetables or fruits, then exclusive breastfeeding practice and less bottle feeding, and hygiene hypothesis or poor hygiene like large family, overcrowding, these are the things. And good vitamin D exposure due to sunlight. So these are the associations. Why? But there is no such evidence is there. And these are the food allergy or proteins or different types of foods by which there is a chance of outgrow. So if you looked at the cow milk outgrow by 70% or 50% by 5 years and 70% by 10 years. Egg, same thing by 70% by 6 years. Then coming to the peanuts, 80 to 85% persist lifelong. Shellfish totally persist for lifelong. So if you are going to treat something regarding the food allergy, you should know what is the behavior of that allergy. If it is peanut and if it is shellfish like prawns, so you should be more careful that this is going to be long persistent. So you should go for the treatment. But in the other hand, cow milk allergy and your egg allergy, these are chance of outgrow. So we should wait for the natural tolerance develop so that it will not bear any cost or there will be no problem with the family perception and as the physician perception. Then coming to this is the role of family and the physician to decide what to do, whether we go for avoidance only, whether we to go for any specific immunotherapy, it is possible. So it will be case to case discussion. On that basis, we have to proceed further. This is the guideline published in the latest literature by then Gallen Food Allergy Group in 2022. They have developed a consensus guidelines taking the evidence from 160 studies all over the world and experts from 18 different countries. So according to them, if you see the green point, oral immunotherapy for age 4 years with severe peanut allergy, they have shown the strong recommendation. Rest others, they have shown the less strong recommendation. And allergy avoidance or allergen avoidance or food avoidance, they have shown for the both all the food allergy, egg and cow milk up to less strong recommendation. So from this Gallen group, it is quite obvious that if you have a child with peanut allergy, then it is better to go for the oral immunotherapy so that it will be better for both the family as well as the physician if the expertise is available and facility is there. There are various published studies. One study in safety and efficacy of sublingual and oral immunotherapy for milk allergy. The immunotherapy in the field of food allergy consists of oral immunotherapy, sublingual immunotherapy, epicutaneous immunotherapy, and immunotherapy with some biologicals like omalizumab, itokimab, or pre and probiotics. These are all these under research product. There is no strong evidence on that. However, what is present, I am telling, the oral immunotherapy was more efficacious in cow milk allergy as compared to the sublingual. It is one study, but we cannot take it as a guarantee oral immunotherapy is better than SLIT. So similarly, another study, oral immunotherapy in children with a food allergy, where do we stand? So they are telling the no unified protocol of therapy, and which makes the comparison between studies difficult because of significant difference in types, doses, and route of administration of allergen. It means we have to be strengthen ourselves in view of a standardized protocol all over the world, so that all will follow the same protocol, so that it will be easy for the data extraction as well as the future outcome. Similarly, another study, allergic immunotherapy and biologicals for IgE mediated food allergy, a systematic review and meta-analysis. They oral immunotherapy, they told oral immunotherapy improves the tolerance while on therapy and is probably safe in peanut, cow and hen's allergy. But others, they have kept silent. So with this data, next is cashew oral immunotherapy for desensitized cashew pistachio allergy. This is a nutcracker study. They are telling while treating the cashew allergy by cross reactivity, you are also indirectly desensitizing the pistachio. Another, the effect of oral immunotherapy in children with milk allergy, the ORIMA study. This is the outcome. The effect of immunotherapy was 55%, but there was also simultaneously incidence of adverse events. So you have to judge the cost, the harm, benefit versus the harm, whether to go for it or not go for it. These are all recent studies from I have taken from 2019 to 2024. So, then JAMA, racial and ethnic representation, mean they are telling what are the studies available, they are not representing the whole in world population. There are certain groups. So you cannot standardize, you cannot generalize the pooled data. That means we have to work from our country so that more data can be generated from our racial region, so it can be added, so make the data generalized. Then coming to the next slide, immunotherapy and oral immunotherapy with omalizumab for food allergy. This is a very recent topic. Some studies in favor of omalizumab in addition to the oral immunotherapy, and some studies they are telling omalizumab there is no benefit in adding in addition to the oral immunotherapy. So there is and still some studies are going on, and some researchers they have advised for a long-term follow-up study on biologicals like omalizumab, itokimab in addition to the oral immunotherapy specifically in allergy to peanuts. Because all the foreign countries like Singapore, Japan, there are highly prevalence of peanut allergy. While in India, we are still, the allergy, I am not getting any allergy till now, but we have two cases, both the cases of peanut allergy, they are NRI. They have born at USA and then they have come to India. The two absolute peanut allergy cases we have in our database, but they are outside India because they have not born here. But however, in India as such, self-reported peanut allergy, self-reported food allergy is much more as compared to the true food allergy. So, then immunotherapy for food allergy, exploring the new targets and innovative strategies. What are the new things? Here they are telling like trained specialist, then standardized protocol and collecting the long-term data. These things we are lacking. So they are telling everything is okay, we will understand everything, but these three things, if standardized, if strengthened, then the data quality will be much more efficacious as compared to the present. Then emerging approaches to food desensitization in addition to your oral immunotherapy, they are telling innovative approach like less allergenic while maintain the immunogenicity, like hypoallergenic milk formula, the formula in which 90% of the cow, if you will give to the 90% of the children to the cow milk allergy, they will tolerate. It is called hypoallergenic milk formula. And some adjuvant treatment like probiotics, prebiotics and anti-IgE like, as I have told, omalizumab, itokimab. But these are the studies undergoing till now. We will get this we'll get the result I think in next 3 to 5 years. So till that we have limited data, and more than half of the patients were able to maintain the targeted milk dose by oral immunotherapy in persistent cow milk allergy from 11 years experience in Finland. So all the data they are telling in cow milk perspective, oral immunotherapy is better than SLIT. But as my from my institute experience, what I passed from, sir was used to go for lots of cases of SLIT. So it may be some racial difference, it may be some racial variations, so that and the child was doing well. One child showed to us in 2019, one child having so much severe of cow milk allergy, child was having, supposed to get symptom, even another neighbor, they are starting boiling the milk. Even the smelling the milk, the child start the symptom. And I think the child is now being okay. Karthik can elaborate a little bit later. So these are the things. And oral immunotherapy for food allergy, these are the some challenges you can tell, because it is a very time consuming procedure. You have to be dedicated setup, you have to do the oral food challenge test first, then dose increment every 15 days, then over 3 to 12 months, build up phase, then maintenance phase. Maintenance phase will be several months to years. Before maintenance phase, again you have to go for oral food challenge, then after maintenance you have to go for the again oral food challenge to decide whether there is a sustained unresponsiveness or there is a tolerance. The basic difference between sustained unresponsiveness and tolerance will be sustained unresponsiveness will be up to a definite time period. After that, there will be again revoking of the signs, while tolerance will be a downgrade symptomatology for indefinite period based of the immunological changes in the Treg cell pathway. So these are the studies done over the past 20 years from different countries like UK, Spain, Japan, Korea. They are all the studies based upon the cow milk allergy, and some were RCTs and some were non-RCT like observational study case control. They are telling oral immunotherapy may be an option better than SLIT in cow milk allergy setting. And this is the conventional versus the modified oral immunotherapy protocols, in which conventional you have to initial day escalation, then build up phase, 20% increment for 2 weeks at hospital. But in advanced or in modified version, you have to initial escalation same as the conventional one, then build up phase, there will be 5% daily increment at home, then 25% increment per month at hospital, in which you will have a short and rapid response if you have the facility. So this is the basic idea. Another terminology in peanut allergy is early oral immunotherapy. Means less than 4 years if you are starting the peanut allergy treatment, it is called early oral immunotherapy. So long-term open label extension, study of the efficacy and safety of epicutaneous immunotherapy. They are also telling the results of the epicutaneous immunotherapy treatment for peanut allergy beyond 1 year of leads to continued response from a well-tolerated, simple to use regimen. They are not telling it is a better and the best, but it is definitely it is an option for peanut allergy for early immunotherapy. Then immunotherapy and biologics, just I have told is the same, another study from the allergy journal. Long-term outcome data is lacking. They are also telling the same thing. Then ASTHMA studies, this is the efficacy and safety of the oral immunotherapy with the AR101. Like Palprogia, FDA approved in 2020, AR101, it is a drug, it was in I think 2018. They are telling this, they are discussed regarding the efficacy and safety of the oral immunotherapy approved for peanut allergy. And they are also telling it is quite beneficial in treating the children with peanut allergy. Then low dose peanut oral immunotherapy in children. These are all the studies, most मोटी जितने भी हैं सब कुछ peanut allergy based upon the peanut allergy, because this is the most difficult treatment in the food allergy as compared to egg allergy and cow milk, because there is a chance to outgrow. But here peanut allergy 80 to 85% they will persist whole over the life, and child will get, it may be in some cases there is high chance of anaphylaxis. So you have to get ready with the adrenaline or EpiPen injection, whichever is available. Then food immunotherapy for children and food allergy. They are also same thing, presenting the encouraging result in the treatment of children with food allergy. They are telling immunotherapy, maybe oral immunotherapy, maybe sublingual immunotherapy, maybe epicutaneous immunotherapy. They are definitely better than doing nothing in a case of food allergy. And early oral immunotherapy means immunotherapy less than 4 years of age for sustained unresponsiveness. Then oral immunotherapy for food allergy children, a pros and cons debate. That the conclusion, it should be open option provided by the specialist team when both patients and their families are prone to adhere to the proposed protocol. There is no fixed, it is highly flexible. If doctor is ready, patient is ready, proceed. If doctor is ready, patient is not ready, you can counsel it. When patient is ready, doctor is not ready, or doctor is not so much confident in doing this, you have to go for some specialist care or specialist center where it can be done. So they are telling the same thing. Then epicutaneous immunotherapy, as I have told, it is another study. They are also telling with the peanut allergy. Then oral immunotherapy is the same thing, another study. Long-term sublingual immunotherapy for peanut allergy in children, clinical and immunologic evidence of desensitization. They are telling extended therapy of peanut, SLIT, sublingual immunotherapy, provided clearly meaningful desensitization in the majority of children with peanut allergy that was balanced with ease of administration of unfavorable safety profile. It means, may it be oral immunotherapy like Palfogia or AR101, may it be SLIT. If you have the standardized allergen, if you have the expertise, if you have the center with all the facilities, you should provide the option to the patients. But luckily, the original peanut allergy is not till date in India as per the literatures. But hope, as we are advancing in the field of pollution, Delhi abhi dur nahi. So by 2040, we may get cases of peanut allergy, if my sir was not wrong. Then Yaki task force guideline, they have searched quite a big database and published a guideline on different food allergy. And if you see this table, this left right, 2 minutes, okay, thank you. If you see the table, all the red colors are for the peanuts. So there are lots of studies published on the oral immunotherapy, sublingual immunotherapy about the peanut, as compared to less study compared to peanut, less in the milk and सबसे कम है आपका egg में. So they are telling poor methodology, then paucity of long-term follow-up data, then poor understanding of the outcome. These are the gaps, and they are also they have told how to overcome this gap. Then there is a Cochrane library where oral and sublingual immunotherapy for egg allergy. They are telling oral immunotherapy and sublingual immunotherapy both are efficacious in treating the egg allergy patients, but it depends upon the standardized protocol as well as the physician's competence. Then sustained outcome in oral immunotherapy for peanut allergy, POE study. They are also telling the same thing. Omalizumab, as I have already told. Then recommendation, they have given some Galen 2 task force given some recommendation. If you see, the highest level of evidence is for offering peanut oral immunotherapy. Epicutaneous immunotherapy, moderate evidence. Hypoallergenic hydrolyzed cow milk formula for cow milk allergy, moderate evidence. Avoidance of offending food, low evidence. So as of now, the Galen group in 2022, we have to work upon this guideline. This is the latest guideline developed by them. And these are the things like adding the itokimab or omalizumab, they are telling very low. They have not say anything. No recommendation to add any such biologicals in addition to the oral immunotherapy. So that I was telling, after in the 2040, these are the prenatal epigenetic changes, like a fishbone diagram I have presented. This will change the genetic makeup of the child, and in 2040 we may get some peanut allergy because of these changes in the maternal or changes in the baby's genetic makeup in the maternal womb, because of so much factor of like probiotic, bacteria, viruses, farming, pollution, antioxidants, plus and minus. So these changes may happen so that we get much more cases of peanut allergy in 2040 and above. Now coming to the sensitization pattern of various food allergy in our center, because we have done around 300 SPT in last 2
Running
years.
here concise, please.
Okay.
We are running truly after some time.
Okay. So we are getting only the sensitization, not the definite food allergy. And highest is the shrimp cross-reacting with the house dust mite allergy or yellow allergy. The problems in our country: ignorance of the practitioner, lack of diagnostic facility, and not considered as a specialized subject like allergy. Take home message: treatment option for immunotherapy is food allergies, oral immunotherapy, epicutaneous, sublingual, and OIT with IgE, as I have told. Till that only option is oral immunotherapy with strong recommendation for peanut, while moderate recommendation for cow and egg. For all other FA, avoidance and IM epinephrine is still the choice of drug. Biological like omalizumab, itokimab has very low level of evidence in the management of food allergy are adjunct to oral immunotherapy. Early oral immunotherapy and modified oral immunotherapy for peanut, milk and egg are the future. Long-term follow-up study and universal standardized protocol in the need of the hour for management of food allergy in the field of oral immunotherapy. Thank you for the patience listening and taking extra 5 minutes, I think.
Not an issue. It was a vivid deliberation. Thank you so much.
Okay, thank
and in the next, it was our fault that we could not allow you much more time. It was a very good presentation. Thank you, sir.
Thank you, thank you.
Now I'd like to request for the twin lectures, harnessing the digital tools and AI for allergy and immunotherapy care. Here we have one allergy specialist and one AI expert. I would first call Dr. Karthik Nagaraju from Chennai as an allergist to deliver his part of the talk, please.
So good afternoon everyone. After that exhaustive session, after a post-lunch meal and also a food allergy lecture, we'll discuss about how certain tools are available at our disposal where we can use them to improve our clinical practice. So I'll strictly limit myself to a clinician's perspective of how to use certain digital tools and artificial intelligence to enhance allergen immunotherapy care. So we saw earlier that allergen immunotherapy is one of the oldest and currently the only disease-modifying therapy available for IgE-mediated allergies. Although there have been several advances over the years, we have that there have been improvement in the safety and efficacy and accuracy of response also. But the COVID-19 pandemic was an eye-opener, which is when we realized the need and how we can scale up from the need to build up a healthcare revolution where we can develop digital health services that can access and provide services especially to chronic health condition care. So the objectives of my presentation will be to look at some of the challenges and introduce the challenges in allergen immunotherapy care and look at the brief overview of the digital tools and how we can integrate them for our immunotherapy management. So we'll look at a patient timeline when they present for allergen immunotherapy. They usually present with early symptoms. They undergo multiple treatments with over-the-counter treatments, outpatient visits, self-medications, and they develop multiple exacerbations and then get treated in multiple hospitals. And then by the time they get referred to an allergy specialist, there's already a significant delay from their presentation to their diagnosis. They undergo evaluation, and each evaluation per se has its own small delays in establishing diagnosis, and by the time you come to a decision after taking all of them, and then allergen immunotherapy is started, and then now the patient has to be adherent to the therapy. He should not discontinue and take it for a longer period of time, and then he provides benefit and then he stops therapy, and you wait whether you're going to have any further problems or not. However, the scenario is slightly different for an allergist once he starts prescribing an allergen immunotherapy. Here, the allergist has to take a detailed history, look at all the seasonality, exposure, severity, do an assessment, detailed assessment, including skin testing and all your provocation tests, interpret all these complex results together and reach an appropriate diagnosis, select adequate targets, and then you look for, counsel them for therapy, and only in them those who agree for therapy, you start looking at, are there standardized allergen products available, will this therapy work or not, are some of the treatment decisions you are still not sure of at that point of time. You don't know whether SCIT to give or SLIT to give, but whichever option is available, you'll go ahead. And then you modify the treatment based on whatever patient develops side effects, and then there is always going to be some delay, some discontinuity. Finally, when the patient is completing treatment, you now say, okay, there is improvement, so I stop it. But are we documenting what improvement? Are we documenting how much of an improvement is there from beginning till later? So there are several challenges in a management during this traditional method. One of the most important ones will be diagnostic delay and inconsistencies with it, where there are multiple informations available, inadequate collection of information, and interpretation of this information also results in incorrect diagnosis and incorrect allergen immunotherapy prescriptions. This is more so common, especially in scenarios where there is polysensitization, where multiple allergens are positive, and you don't know which one to choose for therapy also. Some of the important things that can also happen from a patient side or patient adherence point of view, where because of improper follow-up and because of or frequent follow-up, frequently visiting the doctor for immunotherapy, or because of problems, they have non-adherence, and there is a lack of motivation and self-motivation, especially when they're taking sublingual on their at home. It is the patient's self-motivation that determines them completing the therapy, and how well that can that will also determine how long they take treatment, and do they complete the entire 3-year or 5-year treatment also. Some of the important monitoring treatment outcome related challenges are inaccurate data collection. At the time of beginning therapy, there is not much accurate documentation of patient severity, stratification, and identifying potential biomarkers which can be identified to look for objective and subjective evidence of improvement to say, yes, I can stop my immunotherapy over a period of time. So there is disease stratification issues also, and there is no real-time reporting of symptoms. Suppose patient develops a symptom, by the time they visit the doctor and say, I have developed a symptom, for us to make an adjustment in the treatment also, there is already a significant delay. So there is no real-time adjustment of treatments also. So to address this, there are several tools that have come up which are looking at digital tools. One of the important ones would be to look at usually mobile health applications. Some of the mobile health applications are mentioned here, and there are certain tools which are available to improve decision support systems, to improve diagnostic probabilities, which diagnostic tests to be done, and also whether timely referrals are required or not. Some of the extra tools that are available that we already know about are telemedicine and also wearable devices which are helpful in monitoring continuously about the patient's response. So there are more than 1,000 allergy-related mobile health apps available in Europe and in USA, but less than 10 are actually found to be relevant with regards to a person-centered care or an appropriate point of care. So these are 4 common and most recommended allergen support apps available. One of them is MaskAir and this Bacvia LR. They are commonly used and recommended by your ARIA guidelines also. And this MaskAir is even considered as a medical grade device because it is helpful in identifying and follow up over time. And you're able to integrate real-time symptoms with pollination season, where the patient reports, okay, today my symptom is worse. This is how bad I feel today. And then the app also correlates with the pollen season at that point of time. What is the pollen count in the air at that point of time? And tries to correlate this information to follow up over a period of time in real time. So the important points where these come useful are in symptom monitoring and stratification. These apps have the ability to identify the symptom severity, and you're also able to develop what is called as mobile health biomarkers. What we mean by mobile health biomarkers are electronically collected severity scoring systems based on visual analog scale or patient perception of symptoms. In addition to medication score, you are able to develop something called as combined symptom and medication score, or ASTHMA score, or a combined asthma, allergic rhinitis and asthma test scores. And these scores are objective, and they have been found to have good follow-up data, and with this you are also having objective evidence of improvement or worsening during your symptoms. So this is how the app reports a symptom with severity and control, and depending on the pollination season, this is the patient who has 2 symptoms during 2 separate pollen seasons, and you have documented evidence that they are most likely secondary to birch pollen or grass pollen during 2 different pollen seasons. So another important situation where such tools are useful are in polysensitization patients, where it helps in improving diagnosis. The left picture is where you're using a established calendar in your hand, hard copy of a calendar. In this calendar, there is mention of all the different pollens in your area and the different season in which these pollens are available. Based on the patient symptoms, you are able to narrow down to 3, 4, maybe 5 allergens. But based on a real-time reporting system, where based on the pollen calendar or pollen count in the air and the patient reported symptoms using an e-diary, we are able to accurately count down to at least 1 or maximum 2 allergens for a diagnosis. So it is now being integrated in the German National Pollen Network, where they are now able to use this Mask Air app to identify different phenotypes of allergic rhinitis during their presentations also. So this is there are multiple publications for each of the app available, and they are now currently being used for most follow-up therapy in allergen immunotherapy also. So now we'll talk about what is the role of artificial intelligence. I think the next speaker would be a better person to talk about it. I'll just briefly mention that there is a role for artificial intelligence, and there are 3 subgroups of artificial intelligence like machine learning and deep learning, which further enhance independent decision making skills of an artificial intelligence computer system tool. So this one will help us in personalizing treatment plans based on algorithms, analyze the patient data, look at the severity of the symptom, and optimize the treatment and choose the right allergen immunotherapy options, and improving efficacy and reducing side effects simultaneously. We also use predictive analytics based on the forecast, or using patient outcomes can be looked at, and even select the most effective protocols like rush protocol, cluster protocol, or conventional immunotherapy protocols can also be chosen. We also look at allergen exposure forecasting, where the device can alert the patient that the pollen exposure is supposed to increase, so be on the alert, and even give suggested pharmacotherapy measures or immunotherapy measure adjustments on real-time basis as a feedback to the patient. We are also having something called as clinical decision support systems, where by using data-driven diagnostics, it provides suggestions, and looking at the extensive allergen database, it reduces diagnostic errors and improves the treatment pathways by providing personalized immunotherapy strategies. IT120 is actually a clinical decision support system currently being used in Italy, and it is actually found to include both clinical history, specific IgE findings, component result diagnosis, e-diary, and it makes up recommendations for the allergen immunotherapy. And it has been found that by using at IT 2020 this particular app, in the group of allergist specialists were also recommended to correlate their diagnosis, and there was a significant correlation between the findings of an EIT app and the allergist recommendations. And when they applied this particular EIT app to general practitioners, they found that there was an increase in the diagnostic positivity of general practitioners, where in remote situations where general practitioners may not always be available, such tools will enhance real-time decision support in at least timing referral for therapy. So this is an example of how the clinical decision support system works. This is the patient data in the top, and then the pollen calendar based on the symptoms. This is how you look at it, and based on this, you're able to say, okay, there's a possibility of 6 possible allergens as a cause for this particular patient's symptoms. Then you take the SPT and specific IgE result, and you're able to say with some evidence, okay, most likely there is some 1 or 2 allergens are likely positive. But when you combine this, in the absence of even doing provocation testing, just by looking at real-time e-diary data, you're able to say with convincing evidence that only that grass pollen is most likely clinical relevant and should be the target of immunotherapy even in a polysensitized patient. So if you see that SPT and specific IgE report, there are multiple allergens which are positive, including trees. You need not target the trees, because this patient's symptoms, severity, everything is explained by just a single grass pollen. So based on this, you are able to enhance the accuracy of immunotherapy. And the other tool would be to use for follow-up. How you use it for follow-up is because subcutaneous immunotherapy, the patient comes to the doctor, the injection is taken only in the doctor's presence, and you can use that opportunity to reinforce, okay, you have to complete therapy, you should complete therapy, you're doing well, and this reinforcement works. But for a sublingual immunotherapy, the patient does not have to come back to the doctor. It is his marzi. He can decide whether he wants to come or whether he doesn't want to come. If he is worsening, then probably he'll come, or he'll not even think about you. He'll discontinue therapy on his own because of lack of intrinsic motivation. So this can be solved by using certain efficacy feedbacks by the patient and the doctor efficacy feedback. So the patient also gets an information that, okay, I am also getting better. The doctor also is aware that yes, there is an improvement in the symptoms. Reminder systems for adherence, telemedicine and prescriptions can also be provided. The patient does not have to travel long distances to go and get their medications renewed by the doctor, and even provide digital action plans like for asthma exacerbations. You're able to provide certain action plans for immediate at-home management of your allergies. So likewise, you are able to also look at what is the temporal course of response after starting immunotherapy. So there are 2 points of decision after starting immunotherapy. One is called as early response point, and the other one is called as a late response point. You look at the early response point, which is somewhere around 6 to 9 months period, and depending on the patient's real-time reporting of symptoms, you're able to say, okay, this patient does not have any response, so you're able to stop therapy. And for somebody who is responding well, after completion of a fair amount of immunotherapy, let us say 3 years of treatment, looking at the improvement and objective improvement in the symptom scores, you use that opportunity to discontinue therapy further. So this is going to be a real-time feedback tool of non-responders and also for detecting compliance. So at the end of the day, we want something called as a blended patient care approach, where the extension of a hospital or a healthcare provider is extended up to the home, where the doctor is now able to provide, prevent healthcare overload and even provide involvement in his own health, in the patient's own health. And when a doctor's involvement is there, it improves the adherence of the patient to documenting their symptoms also. So this is where telemedicine adds more to patient-centered care also. So there is a prospective recording of symptoms and data, monitor side effects, and even evaluate treatment efficacies. So some of the research final applications that I can think of are in such situations where there is no need for doing randomized control trials, because randomized control trials use strict criteria. Real world patients are not included in randomized control trials. So we need what is called as real world effectiveness data, which is including patients with morbidities, with a real patient who has the ability to take medications, multiple severity of asthmas. So such patients can be included, and their symptom diaries could work as new biomarkers to look at efficacy or effectiveness data, and we might be able to provide it. So this is an example of how symptom scores were used to differentiate between the treatments, even though they were not given simultaneously. Pharmacotherapy versus immunotherapy could be easily compared across 2 different regimens in a non-randomized control trial situation also. So it also helps us in prediction of response, where by using machine learning and artificial intelligence, where all the information that is gathered over the years, all the clinical, biochemical, all the data is put together, analyzed. We look at what is called as cluster analysis and neural networks. You generate new development of thinking processes and develop your own algorithms, and therefore identify what is called as a theratype. What we mean by theratype is the phenotype or endotype, we keep talking about it. Theratype is nothing but a person we are able to predict responders to treatment or non-responders to treatment even before starting therapy. So based on these, we are able to come down to certain things. So still, with digital health and artificial intelligence, I look at there are still certain challenges, especially a single tool may not fit all. We know that there are four apps I showed you. Even one of them is not comprehensive. As per the recommendations or requirements, it is not enough to supplement all the data required. But the choice of support needs to be individualized to the patient's requirements and the preferences. There are obviously going to be language and technical issues in a country like India, with every state and every region having their own language, and scorings and their understanding of symptoms and reporting symptoms will be an issue. Access to digital tools are not always easy. Patients may be having a cell phone in their hand, but having the ability to report their own symptoms may not be easy for them. Cost may be mildly, slightly added cost, but we may have to look at how the cost can be working out in the future. We don't have a lot of local or regional data. So how artificial intelligence works in giving feedback is what information is provided to it will determine how it interprets the result and provide you suggestions. If you give poor quality data, it will give you poor quality suggestions. So more quality, better quality actual studies are required, and this data will be supplemented and provided to artificial intelligence, and that can be utilized for providing real-time suggestions. There's always going to be ethical and data privacy issues. I think this will be dealt with better by the next speaker. So digital health is useful for early patient stratification, for appropriate diagnosis and prescription of therapies, for improving the patient blended care and follow-up, and also for improving adherence as a reminder, and for documentation of symptom improvement score also. Where artificial intelligence also plays in immunotherapy would be assessing all the database and biomarkers, like I suggested, in predicting biomarkers for improvement, biomarkers for providing cost-effective care, whether we can stop immunotherapy early or not, and by also looking at data mining to provide research purposes also. So in conclusion, there are broad spectrum of possibilities with where there is a prediction of responders to allergen immunotherapy, personalized digital support, especially in complex case scenarios, effective patient-doctor communication can be improved, and there is also appropriate and timely diagnostic workups, which improves only adherence, and at the end of the day, we all want our patients to improve, and all patients want to improve with appropriate therapy. So thank you.
Thank you, Dr. Karthik. It was really well-encompassing talk. We have learned about the theratypes concept, the concept which is going on in NHS and all. We have also talked about the personalization of allergy treatment, inclusion of HCP, and chances of more adherence, the differentiations between SLIT and SCIT, which we commonly face. So actually that's true, and you have also mentioned about data mining, which is I feel something to look forward, and especially in a country like ours with so much diversity in language and everything, culture, tastes, belongings, economic capability and all. Yeah, that's true that it remains a very good arena for research and something to do about. And now with that, I will request our very own Dr. Amit Dey, AI expert, our elder brother, a very known person in the field, very well-known person in the field for the digital aspect of it. Thank you.
कहाँ पे जाएगा इसमें ना this gathering. A very well done job by Karthik. I think he covered the whole spectrum. Thank you for the introduction, and thank you, Shambo, for inviting me, and to the organizers, of course. I hope my slides will come, and I'll be presenting live. And the beauty of it, has made this presentation in almost 10 minutes using artificial intelligence. So we need to walk what we practice, what we preach. Ashina? Ashmina? So we say that this is a technical glitch, and it's always auspicious when you do a technology talk. So is it? Okay. All right. Yes, sir. Something has come. No, ulto na. Screen configuration কিছু চেঞ্জ করতে হবে?
না না, এটা সাপোর্ট নিচ্ছে না।
সাপোর্ট কেন নেবে না? HDMI পোর্ট তো
হতে পারে, HDMI-টা বন্ধ করে দেবে।
HDMI সবসময় রাখতে হবে।
এটাই তো এই তো দেখেন লুজ হচ্ছে।
কনফিগারেশন নিচ্ছে না। কনফিগারেশন নিচ্ছে না। স্ক্রিন রেজোলিউশন কনফিগারেশন নিচ্ছে না। দ্যাট ইজ হোয়াট ইজ হ্যাপনিং। তোমার এই স্ক্রিনের ওখানকার স্ক্রিন রেজোলিউশন এখানকার স্ক্রিন রেজোলিউশন ম্যাচ করছে না।
ল্যাপটপটা ওখানে লাগে না?
হ্যাঁ করে দাও। গো টু দ্য নেক্সট স্লাইড করলে তুমি মুভ করবে, এটাকে প্রেজেন্ট করো।
ঠিক আছে।
স্লাইড চেঞ্জার দিয়ে মুভ করা যাবে? লেট মি সি। Okay, so let me be very extempo here. I mean, I think Karthik has covered almost all the aspects of application of AI in allergy and immunotherapy. So let me try to give you a brief understanding of what we are dealing with here. So artificial intelligence, you know, as we all know, is that branch of computer science in which you have a set of data, and that data is supposed to be giving us some information, and from that information we are supposed to be driving or drawing some conclusions in the form of knowledge or intelligence. So three very important aspects is required. That is, there needs to be a data, there needs to be some meaning coming out of the data, which is information, and from that information there needs to be an intelligence that is coming out of it. Now, in the spectrum of healthcare, the biggest advantage of using artificial intelligence is going to be personalizing treatment. So we are looking at more and more precision medicine coming out and more patient-centric care coming out. So how this is going to happen? So from the data, we will be able to derive that information that will be driving these algorithms. Now, there was a slide which Karthik had showed, that is, the whole spectrum of artificial intelligence has a subspectrum called machine learning, and a subspectrum of machine learning is deep learning. So I'll speak extempo. Unfortunately, the slides will not support. So in the domain of machine learning, we are primarily looking at a model or an algorithm that is going to be picking up the data points, and that will be mapping and giving certain predictions. Now, for example, let us say we have a data point which is talking about adoption to the immunotherapy, or looking at the genetic profile or the metabolomics profile of the individual and giving certain category of predictions from the data. So that is what machine learning is going to be able to do this. Now this whole context of machine learning is actually not very new. It is something which has been happening over many years. And there are three categories of machine learning that we talk about. One is supervised learning, one is unsupervised learning, one is semi-supervised or reinforcement learning. So basically in supervised learning, what happens is we are giving a training set of data. So the algorithm is trained on a set of data. And then there is a testing set of data on which it has been tested on before it is applied into a real world deployment. In supervised learning, basically the points are annotated or labeled. So there is explainability of how the prediction is coming, and there is more explainability and transparency in a supervised learning. In an unsupervised learning, you are looking at allowing the machine to learn on its own and pick up certain patterns. And this methodology is primarily used in the domain of statistics for clustering analysis. And I think Dr. Karthik had shown a slide where he was speaking about that, we can cluster the patient as to how they're responding to a certain category of treatment in this whole domain of allergy and immunology. And this might apply in all the domains of healthcare. As a diabetologist, as a chronic care physician, this might happen even in the field of metabolic medicine. So one is picking up predictive analytics and stratifying the risk of the individual, clustering them, and then in a prospective way, we can get some analytics that can predict how the patient is going to respond to certain kind of pharmacotherapy, or what is the risk score of that patient in terms of their demographic and geographic population. So that's one application of artificial intelligence, and there is going to be more and more research-driven and real-world data-driven kind of an approach that we are looking at. So what we have been all doing so far is we have been looking at evidences which, in a hierarchical way, we are looking at real-world, we were looking at clinical trials, meta-analysis, systemic review, and eventually we were coming into our real-world studies. With artificial intelligence and machine learning coming in, you will be getting more data-driven intelligence coming in, so the real-world studies will get more and more evidences and more importance beyond the scope of the clinical trials and the RCTs that we talk about in the hierarchy of evidence in medical literature. So this is going to be taking us to the domain of a shift, not shift, but an add-on to evidence-based immunology or evidence-based medicine into a data-driven intelligence-based medicine. And that's where we are shifting the gears into more precision care or more personalized medicine. The other aspect of application of artificial intelligence, as I said, one is supervised learning and one is unsupervised learning. And there is something which works in between, that is semi-supervised learning, where you allow half the model to be trained with the knowledge of your training set of data, and the other half you allow the model to learn from the data itself. It's like, allowing the intern, you're giving some kind of a guideline and training to the intern of the hospital. At the same time, you're allowing the intern to go out in the wards and learn on his own. It's somewhat like that. And the other terminology which is there in machine learning is reinforcement learning, which is learning through negative and positive feedback. Now, this methodology is very important in the context of healthcare, because this is where the model tends to learn and starts thinking like it's supposed to think like a doctor, or predict like they're supposed to predict in medical science. And it gets rewarded in a positive or a negative way, depending upon how close it is to the actual response. And it's like a methodology which is used in gamification. So in machine learning, we have spoken about supervised, semi-supervised, and reinforcement learning. And the other domain of subset of machine learning is deep learning. Now, deep learning is basically where we are analyzing images. I do not understand how much it will hold importance in the field of immunology or allergy, but largely in the field of pathology and possibly in genetic profiling, there is going to be a lot of use of these deep learning models which are working with the principle of convolutional neural networks. So neural networks is a term which means it mimics the neural networks of our brain, and it undergoes, I wish I could show you a couple of photos, but I think Dr. Karthik justified by showing you some of them, that it undergoes through multiple layers of iterations and helps in predicting certain diseases or helps in predicting certain outcomes by analyzing that particular image, again when it is labeled and annotated as one-to-one. So this is conventional artificial intelligence that we are going to be looking at in use, largely in all the technology or a part of AI, a part of deep learning to be specific, that is able to generate text, image, audio, or video in response to a request or a command which I'm giving to the system, which is basically called prompting. And this methodology in which I am speaking to the system and the computer is coding it in its binary code, but it's responding back to me in my language, is actually through the methodology of NLP or natural language processing. That's what happens in the back end. So now if you try to contextualize the application of generative AI in the field of, let's say, immunology, you could use it in the form of virtual chatbots. I think that's an example that Karthik spoke about. So what happens is in the back end, there is going to be a language model that will work. Language as in natural language processing. Model means it has been trained on certain set of data, which is a transformer model or foundation model, as we call it in the domain of AI or technology. And this particular model is actually going to be generating some response in the request of the command that is put in. So now try to contextualize in health education or adherence to the treatment, or even in decentralized clinical trials. We were speaking about this with Shambo in one medical college. There could be the use of these virtual AI chatbots that could improve adherence of the patient through timely education and timely information with the right content. And this actually works with the principle of just-in-time adaptive intervention. It mostly works in chronic care. Even I believe immunotherapy is a kind of a chronic care because it needs to be continued over a period of time, and it needs more patient adherence to the treatment and understanding of the patient into what is being offered to them. So just-in-time adaptive intervention means tapping the patient with the right information at the right point of time to bring the right behavioral or modification or compliance to the treatment that will impact the treatment's outcome. And with the help of generative AI chatbots, this is a possibility now. But again, when you're using a generative AI chatbot, the question that all of you will ask us is, where is the data privacy? Where is the data security? Where is the data going? How validated is that response? How ethical is that response? Will it cross the limit and start acting as a doctor and overshoot the response it is something to give? So that's where the validation and the evaluation of these tools needs to come out. So largely, in the domain of immunology, what I strongly believe, one is the predictive analytics. Second is the drug discovery. Again, the drug discovery will use a lot of machine learning, a lot of natural language processing, a lot of deep learning algorithms. And the other important aspect is going to be the use of these virtual chatbots to educate the patient and to improve the patient adherence to the treatment. Now, going down the line, there needs to be two questions that needs to be answered in the domain or application of artificial intelligence in the field of healthcare. One is the ethical question as to how safe the data is, who owns the data, where is the data being stored, where is the cloud server that is being used. And as we stand today, we don't have a clear-cut answer to this because the global guidelines are evolving on the use of artificial intelligence. But trust me, if you have been following the developments that has been happening, Prime Minister Narendra Modi had been, he was co-chairing the AI summit in France recently, and that was a global summit where they literally discussed about how AI should be regulated in different domains, including healthcare across the globe. So countries are kind of putting their brains in to figure out a way how this data privacy and data regulation can be taken care of. As we speak, there are guidelines, there are regulators. One is the HIPAA. Of course, we have all heard of the term. In the US, the Food and Drug, FDA has gone a long way in providing a lot of guidelines as how the AI tools or the AI algorithms should be regulated. And they have now a separate wing which approves the AI algorithms. And also you have the GDPR, which looks at the data privacy and the data protection in the European Union. In our country, we have the Digital Data Protection Act, which is the DPDR, which has been recently passed by the Parliament. And also, if you look at the Bharatiya Nyaya Sanhita, that also speaks about digital protection or the digital privacy and the digital security. The end of the day, the answer to the question is who owns the data when these chatbots are going to be used or when the data will be de-identified and analyzed for predictive analytics. Well, the patient is the owner of the data. Neither the service provider or the end user, which is the doctor in this case, is the owner of the data. That's how it should be. As we evolve into a country with ABDM compliance, we are going to be looking at this transfer of data from one system to another coming out. That is data interoperability. So let's say, for example, Dr. Karthik is looking at a patient and he is using his set of electronic health record, and he has picked up in his clinical decision support system, which will be having a generative AI chatbot or an agentic AI, certain kind of a pattern of the patient's response to certain immunotherapy, and the patient shifts from his city to Kolkata, and the patient gets transferred to Dr. Shambo. So he can have a UID access of this particular patient into his EHR, because both the electronic health records are interoperable, and the patient will give a consent by giving an OTP, which the patient will have access to, for Dr. Shambo to access Dr. Karthik's patient's record. So as a result, his data intelligence, which he has captured from the years of monitoring of the patient, which is a real world intelligence, gets translated into the doctor who is seeing the next, and the treatment can be continuously carried forwarded without creating any bias, and with having that data-driven intelligence brought into the treatment, understanding that this is what works in a precise way for the patient, and that will help us in maintaining the standards of care across all the levels. As we speak here today, all of us might be fascinated, as might be like what we are talking about, what Dr. Karthik and myself showed. And I was actually about to show that last slide that he had showed, where he had actually shown a beautiful system of the EHT and the CDSS, how there is going to be an interoperable operation between all the levels of healthcare provider in the field of immunology, allergy, or any other field of medicine, and they'll be integrating, and like, the systems are going to be talking to each other to give an intelligent response. Although these sounds quite futuristic, but trust me, in the next 5 years, medicine is going to revolutionize with more and more precision care and personalized medicine coming in. And the source of this is going to be the data. So one very important point is, no matter how we are seeing the patient, this data needs to be digitalized, because without numbers and strings, absolutely there is no value of the data. Also, when the data gets digitalized, it is important that we have a structured set of data. And then from that structured set of data, structured as in clean data, complete data, we are able to derive some analytics and some information coming out of it. The end of the day, what this is going to do is it's not going to replace an immunologist or an allergy specialist or a physician. It is going to augment the decision-making capability of the clinician. If you have an agentic AI, which is complementing the decision-making capability of an allergy specialist, in the clinical decision support system, it's going to be acting as an augmented intelligence, which is going to be guiding the clinician over and above the standard set of guidelines with the personalized data-driven information from the patient into taking better clinical decision. And this is what we are heading into, because we are now going into the era of precision medicine, genetic profiling, metabolomics, and various other personalized care methodology. So I will invite all of you to start getting curious about how AI is transforming your domain. That's where you get an intelligent clinical decision support system, augmenting your day-to-day clinical workflow, reducing the administrative burden and improving the intelligent quotient and helping you, augmenting you to take better clinical decisions. I will leave you all with this thought that in the era of precision medicine today, we are gradually drifting, as we said, not outweighing or undermining the importance of evidence-based medicine, but we are gradually shifting the importance from evidence-based medicine to data-driven, intelligence-based medicine. And when this shift is happening, it is important that we as clinicians do not go into the back seat as followers, but come into the driving seat as drivers, because we are the domain-specific expert that can identify the need gap and solve the problem that needs to be addressed. So today, as much as we understand our medical jargon, we must be bilingual and understand the technology jargon of artificial intelligence in your specific domain, which is immunology and allergy. I hope I could do justice as an extempore speech without the slides, but I really thank Karthik because he literally showed all the slides. So after he gave you the whole scope of immunology, application of AI in immunology and allergy, I think giving you a little bit of technical nuances will do justice to this August gap. Thank you very much.
Yeah, with that, this guy, I believe, because he had already showed which you had to show. It was a very comprehensive one. So I was thinking that what you would say.
Literally,
so this, this, a preconditioning was there. I can request all the speakers to come up the stage, please, and also Shamoda to come up the stage, please. And if you have any question to any one of them, one or two, anyone.
Usually in an AI talk, there should be one or two queries coming in, one or two questions shooting up. So either we've all understood everything or it didn't tickle our senses.
Very recently, with Dr. Amit Dev, my good friend, we had published our book on AI, and it is targeted to the physicians only. If you are interested, you can get that. It is available in the JP website. So now may I invite Dr. Nihar Ranjan Mishra. So please come. So it will be real honor to felicitate respected chairperson Dr. Boyodhidhar and our speakers Dr. Kartik Nagaraju, Dr. Amit De and Dr. Nihar Ranjan Mishra. Please come.
We also have a community called Doctors AI that works on making doctors literate on artificial intelligence, and Dr. Shah is a wing leader, Dr. Dhar is also with us, Kartik will be joining us right after this. We will eventually plan different wings or specialities, so I'm hoping that we can have an immunology, pulmonology and allergy wing that will be working on domain-specific research on this at Doctors AI.
What I also wanted to add was
Fine. Shout out on your voices.
was the fact that
Go on.
So I just wanted to add, AI is currently looked at as there's a lot of resistance when you think about it from the first perspective, but then how you eloquently spoke about it, even in the absence of a digital technology support, you were able to introduce the idea and retain it much better for us, and that actually speaks a lot. So what I felt was, with guidance in the right way, people can be taken or think or utilize the technology in the right way. So experts like you would be the ones paving way for utilizing the technology.
And mankind has lived through the days of evolution, and we have always surpassed that. And I'm sure people fear that AGI will take over and probably it'll overcome human intelligence. But looking at it, the adaptability capability that is there in a human mind, I think that will go beyond any artificial intelligence. At the end of the day, we should be curious. We should be willing to adopt this new technology to augment our work. And most importantly, we should be willing to adapt to the change that is happening every single second. I would say this. Because every single second, somebody is working and building a new model, a new algorithm is coming. And change is the only constant, and disruption is the key in advancement of technology. So we should not shy back and look at artificial intelligence as a competitor. Rather, look at it as your enabler, a friendly assistant that will help you take better clinical decisions in your work.
If I may, it's not going to replace us, it is going to replace us.
Yes,
Replace.
That's all.
चाइना में अभी एक हॉस्पिटल बना है जिसमें 50 AI बेस्ड, आपको पता ही होगा. So that
Agentic hospital.
agentic hospital. So let's see how it works. The total hospital is made up of 50 doctors of AI or computerized, and they have tried with the vision to start in a small scale. And I think at least in next 15-20 years, India will have such, may have.
I don't think it's 15-20 years. I think
In
substantial
the
one
next
from
2 to 3 years, we'll be seeing a foundation model being built in India. That's for
already
sure.
going on.
Okay.
India will come up with its foundation model, and we'll hopefully from Doctors AI will be collaborating also on those. Thank you very much, everyone.
Thank you. Thank you very much. I again want Dr. Kartik Nagaraju to please stay in the stage because for the panel discussion we want your expertise. So please join us as panelists. And also we have Dr. Atrey Rai Choudhury, a very senior biochemist and in charge of laboratory of Allergy Asthma Treatment Center. So may I ask her to join for the panel discussion. And I request all of our doctors who are there, please join, because this panel discussion will be a little bit in an informal way. You are also free to ask questions to our panelists, to us, and you also have right to make your own comments. So may I request one of our very senior physician from Allergy Asthma Treatment Center, Dr. Saurabh Das, please join us in front. It will be great if you also share your experience. Dr. Kallol Pal, please join in front. And also the others, you can coming forward, and there are basic science expert also. I can see madam. So I also welcome your opinion, your comments, because this will be a two-way communication. This panel discussion is nothing formal. So I think with that, may I start with Dr. Karthik Nagaraju. First of all, sir, you had, you want? From the morning, we were talking about history taking as the key to diagnosis. So can you tell us a little bit about the specific points we need to remember during the history taking for evaluation of allergy patient?
Sure. When we look at history is the one of the most important aspects of before you start a diagnosis. Just yesterday I was giving a lecture where I spoke about the importance of testing, but without any adequate history, any result that you get out of it is of no use to you. So history has to be, first you have to be comprehensive, you have to have the patience to take a detailed history even before you begin. And when you look at it, you have to look at using comfortable terms and making the patient welcome to explain everything that they feel, so that you're able to get a comprehensive information. And first and foremost, which we look at, it will be the symptom complex and how they present it. What their most concerning symptoms is their presenting symptoms, like especially like the severity of the symptom, how it is affecting their sleep, quality of life, and their work, school, education, especially in pediatric age group. We also then concentrate on how this has progressed since how many years it has been earlier. Have there been other organ involvements, like for example, if somebody has asthma right now, has there been a prior onset of allergic rhinitis or a prior history of eczema in the past, which can more lead you towards considering atopic march, or the most likely allergens involved, or like the most likely seasons involved, and most likely how when the nocturnal variation is present, or whether there are any diurnal variations, whether there are any identifiable triggers or not in the history. We look for these kind of history from the initial history prior to deciding what tests are to be performed next later.
So just you mentioned about atopic march. Now the concept is atopic dance. So what is your take on that? What are the evidences now we should move from march to dance now?
So previously it was more like a progression only from one organ involvement to the next and others, but now with multiple organ involvements, and there is even reverse variations also. They present in multiple variations, and they keep progressing in different presentations, from skin to rhinitis to asthma, or rhinitis then asthma, and then later on develop a skin. So there is an unpredictability of the nature of the presentations, which can now, that is why the term is now, and the speed at which their progresses are also quite significant, which is why instead of looking at it from a march, the other term that they were looking at it was more like a run. Then they used the term dance because it was a much better term. So now it just is an indication of how severely or how rapidly it is worsening over the years, and it is also an indication of how rapidly it can potentially worsen if this particular progression is allowed to happen over time. So from rhinitis, if there is rapidly progressing, you can expect them to develop an asthma, and if they've already developed asthma, the severe asthma variations can also be predicted to happen. Recurrent admissions can also be predicted. So we should use that term to reinforce the fact that you are progressing rapidly, and that is how it works as an excellent patient education tool also, which we discussed earlier.
Thank you. So now may I ask Dr. Atri Raichaudhuri, I think you are from the laboratory end. Many times you got different types of samples, and I think allergy is one of the field where you also require a patient history. So can you please elaborate a little on this perspective, that how we should send our patient to the laboratory, and what are the prerequisites, especially from the history point of view?
So as we all know, history is one of the primary requirements for evaluation of a patient. Now regarding the laboratory part of it, more than 70% of the errors that happen in the reporting area is pre-analytical. That is, error has started happening even before the sample has come to the lab. So for pre-analytical error, in order to avoid it, we need proper history taking, and we also need to ensure adequate patient preparation. So as we all know, fasting sample is not required for every test. Only for fasting, glucose fasting is mandatory. But what is most important is the medication. That is when we are, for example, testing for total IgE or for absolute eosinophil count. If the patient is continuously taking anti-allergic medication, so in that case we can get false negative results. So we need to stop the anti-allergic medications like Montelukast or whatever anti-allergic antihistamines they are taking at least for 1 month. If it is not possible for the patient to stop the medication for 1 month, since the symptoms may become more and more severe, so stopping it at least for 7 to 15 days is of paramount importance. Otherwise, if the patient is on continuous anti-allergics, then the immune response is already down-regulated, and that way the results may come as false negative, which may be misleading. Also, for the other allergy tests, like for specific IgE, we also need to know the patient's food habit, their exposure, the type of environment they are traveling in, like even insignificant minor details may become handy, like there may be presence of some trees on his way from home to office. Those trees may emit pollens in the environment, which may be triggering the allergic response. So many a times we get different allergens in the samples, but we do not get to identify the source, from where did the patient get exposed. That is why the patient's environment, the home he is living in, what trees are there, what are the potential pollens, pollen emitting trees. These are the very, very minor details which we need to elaborate in order to give the patient a comprehensive and proper treatment.
Yeah, thank you, madam. But one very important issue I want to highlight here: when we send our patient for skin prick test, the medication use is very critical thing that we should screen, because there are many medications, as madam also was mentioning about antihistamine. Apart from that antihistamine, if a patient, for an example, taking amitriptyline, it also has some property which is known as antihistaminic property. So there are certain other group of medications, for an example, dopiapine or doxepine, or even if I am using in some subgroup of patients certain antipsychotic agents, for an example, olanzapine or quetiapine, it is important to have a washout period, because we know from our system the drug will take at least 5 half-lives for elimination. So for an example, if I am taking a levocetrizine tablet, an antihistamine, which has a half-life of maybe around 18 hours or 16 hours, like that, at least we need to give 3 to 5 days time before doing skin prick test. So I think this is an important message, because while I am sending my patient for skin prick test, this drug withdrawing for at least 5 half-lives of that particular drug is crucial. Yes, it is sometimes difficult while I am consuming antidepressant drug or antipsychotic drug, but we need to consult our psychiatric colleague whether we can withdraw that drug, prescribe that drug for a small duration of time. And there are certain group of antipsychotics, for an example, if I am talking about an aripiprazole, which has very least antihistaminic property, and that can be continued. So we need to do the reconciliation while sending the patient for skin prick test. Otherwise, the costly test will become falsely negative. So this should not be done, and I think the medication history is very important. And one issue I just want to ask you, both of you, that often we go undue importance to IgE total, and many of us also think that many of our physician friends also think that yes, we can do the serial IgE estimation, and the IgE is going high, that means my patient become deteriorating, and when IgE is going down, that means the patient is very good. But actually it is not. IgE is something which is very much non-specific. So what is your take on that, and what should be your message? Because many times our patient become worried. They tell, Dr. Saab, my IgE was 1200 last time. After 6 months, I had done my IgE and it becomes now 2400. So I am very much worried. So what is your take? I shall ask first Dr. Karthik Nagaraju to have your comment, and then also
So when we look at immunoglobulin E, IgE is a non-specific immunoglobulin secreted or produced. There can be multiple reasons why somebody produces an IgE. It can be elevated, used to be considered as a tool for identifying atopic diseases earlier, but multiple systematic reviews and studies have clearly shown that it is not a significant or a sensitive tool to identify or pick up atopic diseases. It may be some situations can be used to identify a non-atopic condition where the levels are little on the lower side, but still the positive predictive value or the sensitivity are very, very poor or unreliable. The problem is in India, when there is a ability to access any test, so the patient can do it on their own. This is a very common scenario even in my practice too, sir. They present with earlier it was this level, today it's gone up. My physician, they got worried, and therefore they have referred me to you to do allergy test. But there are multiple other possibilities why somebody develops an elevated IgE, including non-allergic, non-atopic conditions like parasitic infections, or it could be secondary to any medication intake or genetically predisposed individuals, or maybe there must be some non-IgE mediated eczema. These are all other situations where they have elevated IgE levels. And it takes a while to just explain to them that IgE is not because of allergy always and due to other possibilities. And it depends on the technology also. I think there is a lot of difference in the technologies used by different laboratories, and Madam can throw a bit of light on that. There are same IgE values from two different laboratories are not comparable with each other. So you may have different cutoffs and different dilutions used. So the IgE value reported is not compared as apples and apples comparison for IgE also.
Yeah, so what is your comment on that, madam?
Yes, as Dr. Karthik has rightly pointed out, total IgE, the upper limit of detection or the analytical measuring range or AMR varies from laboratory to laboratory and from method to method. It differs a lot. Like in some methods, the upper limit may be up to 1000. That is up to 1000 unit per liter. The total IgE value is properly estimated. After that, they go into dilution. In some other methods, the upper limit of detection is 5000. So, if one lab tests with a method that has an upper limit of 1000 and another lab tests with an upper limit of 5000, and maybe there is some more sensitive test, better methods where the total IgE upper limit of detection is 10,000, suppose. So, in these three labs, once they go into dilution, values may vary like anything. For example, when we are testing with a kit that has an upper limit of 1000, when it goes into 5 dilution we test, we get a result of suppose 2500. But if the same sample is tested with a different kit or a different method that has an upper limit of detection of 5000, and the IgE is estimated without dilution, from that lab the result may come as 4000. But if we start comparing 2500 with 4000 and we start correlating that absolute value with the patient symptoms, it will not match. So if we are going into serial monitoring, what is most important is we stick to one single method or one single analyzer. That way the values can somehow be correlated. Again, the values may differ based on the level of dilution. If we run a test with 5 dilution, and if we run the same test with 10 dilutions in the higher range, the values may differ by 1000 to even 4000. So that way the measuring the absolute value is not always clearly correlating. Another important thing is some allergies may be there which may lead to rise in IgE level at a delayed phase. Like in case of some gastric infections, gastric allergies, that IgE may not rise immediately and it may not correlate directly with the clinical symptomology. So what is most important is in case of serial monitoring, we stick to one laboratory or one method or one analyzer, so that the same patient samples are again and again tested over time with a kit that has the same AMR. And another thing is correlation with the clinical symptomatology. If the patient is symptomatically improving, that means that he is responsive to the treatment, and it should not be directly correlated only to the total IgE value.
Yeah, so as IgE is one of the antibody which is very small sized and very less quantity present inside us, so I think the standardization is very important, and I think we had some level of experiences when generally in our institute we have one protocol that maybe 10 months interval we do check for IgG4 and IgE ratio in those patients who are on allergen immunotherapy. Sometimes what happened, the patient take their IgE from some outside lab, and that time we got some critical perspective to analyze, and we don't match the result with the clinical improvement. I think we have in our audience Dr. Shourav Das, who is practicing in our center more than 10 years almost. So what is your opinion on this perspective, that IgE from one lab or for one patient, or for one patient IgE could be done from multiple labs? So your opinion here.
In my experience, I have encountered many patients who are getting their IgE done at outside laboratory, and as Dr. Apti said that it varies a great extent to lab. So if I advise a patient to do IgE, we always advise them to do it in a fixed laboratory. Previously, where the patient was get done the IgE, the next time he or she must do the IgE from the same laboratory. Otherwise, I have encountered a very trouble in getting the outcome. Means patient is clinically improving, patient is clinically very well, but as per the report, as he has done the IgE from the outside laboratory, I cannot get convince the patient that he is improving. But he or she definitely is improving with our treatment, but it gets confusion in the patient's mind itself. I have a question to Dr. Atri that we are not getting a reference range of IgG4 in the lab report hard copies or soft copies. Patient is most of the time is asking that Dr. report ta ki amar thik ache, because there is no range is given. As I know from my knowledge that IgG4 varies from age to age, and when a patient on immunotherapy, the level of IgG4 may vary from range is not fixed. So I have learned that you will use the IgG4 and IgE ratio when patient is on immunotherapy. The ratio is pointing that if the ratio of IgG4 and IgE is reducing when the patient is on immunotherapy, that he is progressing to our treatment, is improving to our treatment. So may we get a reference range or any fixed idea or direction that what should be the ratio of IgG4 and IgE, or if there is any range of IgG4 in the practical circumstances, so that we can precisely tell a patient that what is the report is.
So see, IgG4 is still not yet very much of a commercially available kit. Very few companies provide IgG4 kit. So the kit we are using, we are giving the absolute value of IgG4 and we are not giving a reference range because the kit has not fixed it. That is why, and it is more like, I'd like to give an example. Suppose when we are measuring sodium in spot urine sodium does not have a reference range, spot urine potassium does not have a reference range, but if we measure it in a 24-hour sample, then we get a reference range. So from spot samples, what we do is we get an estimation of total spot urine potassium to spot urine creatinine ratio to get an idea regarding how much potassium is getting excreted per unit of creatinine. So it is similar with IgG4 and IgE, because both are produced simultaneously in the body. We get an idea from the ratio. We get a better idea rather than producing an absolute reference range. So it is better to stick to the ratio.
Yeah. So
just one small comment on this. When IgG4 is performed, obviously the technologies are different because it is in different antibodies, different reagents, and it is the same patient's blood sample, and with the same lab it might be reliable. Similarly, IgE, specific IgE upon total IgE, is also an excellent tool that can also be used for not only for diagnostic point of view, even on a follow-up tool also they have found that specific IgE upon total IgE is also a tool. I mean, what are your thoughts process? And I just thought that I'll add that point further into
I think specific IgE and IgE total, that ratio is was used in our practice also, but more often we use now the IgG4 and IgE ratio, and as we had discussed since morning, that IgG4 is something which is the protective antibody and the result of Th1 mediated responses that we want, and we can understand, yes, that there is an immunological shift from Th2 to Th1 that happened inside us after allergen immunotherapy. So generally our practice is to do a ratio between IgG4 and IgE after the first vial, that is the starting vial, because we also know that IgE has a tendency to rise in initial few months up to 3 months or like that, 3 months to 6 months, then it goes down. So we do that IgE at 4 months or 4.5 months along with IgG4, and we took that ratio as a baseline for our patient, and then we again do that after 10 or 12 months, and we check the reduction of IgE-IgG4 ratio, and if it is reducing, so we can say that biochemically the patient is improving. And my own thesis was also on that. When we were seeing the effectiveness of allergen immunotherapy, we had done this ratio, and in our research work we also had found there is a marked reduction in IgE-IgG4 ratio. One issue I think we want to specify here, that the IgG4, if we do a specific IgG4, that is more reliable marker. Specific IgG4 and specific IgE ratio, if we can measure that, I think that would be the idealistic marker, and more the evidences now available, they are favoring on this ratio, specific IgG4, that is house dust specific, mite specific IgG4, and house dust mite specific IgE. But unfortunately it is not available in India, and it is I think quite expensive also.
Sometime in the future, but it is expensive.
Yeah, it is expensive. So you want to make some comment? I think that mic is very good.
I also have some comments.
This is regarding, just to share with you, the ratio between specific IgG4 and specific IgE. Yeah, today we are doing the IgG4 as a whole. So the correct figures, correct data, which should be getting to for the treatment of using the immunotherapy, we are not getting the exact result. It is true, 100%. And also we are not doing the IgE, that is the total IgE. Total IgE can vary for some other diseases also. Maybe the patient may be having the warts and other things. That also trigger the IgE. So the question is whether IgG4 specific IgG4 and specific IgE, it is possible or not? Yes, it is possible. Just to share with you, we are coming very soon with specific IgG4, and yes, it is a little bit costly compared to IgG4, normal IgG4. Specific IgG4 a little bit costly, but if the patient is being treated with, say, dust mites vaccine immunotherapy or house dust immunotherapy, so that particular IgG4, specific IgG4 is available. If we go for that, if we do the test, it will be done in immunoblot method. Both the in vitro test, that is the specific IgE, allergy profile, whatever you say, that will be also in immunoblot, and also specific IgG4 also in the immunoblot. So we will get the perfect result as far as the ratio is concerned. That will come very soon. We are going to start in Eastern India.
I think that will be very helpful. But again, till date, I think Madam also wants to have some comment. Madam, till date, what is important? We need to give emphasis on the patient-reported outcome. I think those subjective evidences we need to mark, and I think that tells us about the effectiveness of allergen immunotherapy as a whole. There are well-validated symptom score, and they are very, that cheap, patient, economic friendly. So we need to also promote that idea also. Apart from biomarkers, don't go for the costly biomarkers. At least we need to do a proper evaluation of the patient from their symptom score perspective. Yes, Madam.
I'm the only biologist here, scientist here. So the comment I wanted to make is that there is you all are clinicians. I'm a scientist, so we are more interested in the mechanism of action, the molecular, what is being played out. So first off, there is a immunoglobulin class switching. So the ratio, as Mr. Goswami pointed out, is probably more important than the absolute value of one immunoglobulin or the other, because it's like a amphitheater where so many things are being played out. And being an immunologist, my mentor would always say it's a mess. So in that mess, we are picking out certain markers, but we should also pick out certain patterns rather than one marker or the other. So that's the comment I wanted to make, that there is a class switching. So that is important, and that is a phenomenon that happens over time. So rather than absolute static data, this is something we need to think about. And two, what Mr. Goswami pointed out, যে বিদেশ থেকে আনতে হয়, আমি ন্যানো অ্যান্টিবডি নিয়ে অনেককে বললাম, এটা সম্ভববাবু আপনি সকালবেলা শুনেছেন আমার ছাত্রের বক্তৃতা, এইটা আমরা আনতে চলেছি। সুতরাং আপনাদেরকে দরকার, আমরা ইউনিভার্সিটির ল্যাবরেটরি, আমরা ক্লিনিশিয়ানদের সঙ্গে কাজ করব, এবং আমাদের থার্ড পার্টি, এটা তো একটা এন্টারপ্রেনারিয়াল মোডে চলে যেতে হয়, যেটা ইউনিভার্সিটির ক্লাস নেওয়া আর রিসার্চের বাইরে। সেই জন্য আমাদের ডিসকাভারি পার্টটুকু হয়ে গেছে, এবারে এইটাকে স্কেল আপ করে কিট হিসেবে বের করা। দিস শুড হ্যাপেন উইদিন দ্য নেক্সট 8 to 11 months। সেই জন্য তখন আপনাদের দরকার লাগবে, কারণ এগুলো ন্যানো অ্যান্টিবডি, এটার টার্ন অ্যারাউন্ড টাইম হচ্ছে 2 সপ্তাহ, এটা সস্তা, এটা থার্মোস্টেবল, এটা ছোট, এটা স্পেসিফিক। সেই জন্য আপনি যে কোনো অ্যান্টিজেন দিলে, ইমার্জিং অ্যান্টিজেন দিলেও আমরা অ্যান্টিবডি তৈরি করে দিতে পারবো। আর কার্তিকের সঙ্গেও লাঞ্চের সময় কথা হচ্ছিল যে অ্যান্টিবডির এগেনস্টে আমরা অ্যান্টিবডি তৈরি করে দিতে পারবো। আর যেহেতু এগুলো একেবারে এপিটোপ স্পেসিফিক, সেই জন্য বাইন্ডিং ইজ ভেরি স্টেবল। সো we should be in touch. কাজ আছে।
Thank you, Madam. Thank you very much. And I think this is why we need this collaboration with our basic scientist colleagues. So, as Madam was mentioning, we are also measuring that ratio only in our clinic, the IgG4 IgE ratio. But yes, we need that specific IgG4 to have a ratio on specific IgE. And I think when we talk a lot about IgG4, I will take this privilege, because one of my teacher, Professor Sudip Ghosh sir is there, who is joined in the field of dermatology, and IgG4 is something I think very close to dermatology subject. So if you have, sir, some comment on this, if you want to make.
We usually don't do it regularly.
The IgG4 related disease, you do not have that. So there is one again another arena where we need to do the IgG4 related disease when we face that. So any comment from I think we have now also Professor Shoibal Moitro sir. Sir, if you have any comment on IgG4 related disease and how that can impact the IgG4 count.
Thank you. The IgG4 disease is a rare entity, but there has been reports about IgG4 disease, and we know that how it manifests. It is a multi-system disorder. It usually manifests with the involvement of the lungs, involvement of lymph nodes, and we get typical histopathological features of IgG4 disease. There have been few case reports, and it's involved the same civil law, IgG4 disease. Very interesting disease, manifesting basically itself with the pulmonary symptoms and systemic symptoms as well. Now, the crux of this diagnosing the disease is, under the constellation of the symptoms which the patients come to us with, very high IgG4. This actually points out towards the possibility of the IgG4 causing the disease. As we know, the IgG4 is a very unique subtype of the IgG, because it does not have means the capacity to cause all the effects which typical IgG1 would do. Like we have the antibody dependence and cytotoxicity, then we have the opsonization, the neutralization, and the other things which we talk about. But this itself can also, this anti-inflammatory antibody can also cause disease. They're produced in very high numbers. Now, how this IgG4 disease is going to have an impact on our diagnosis of the IgG4, what we tend to diagnose is specific IgG4. With the Allergen immunotherapy, it actually builds up the specific IgG4 to a specific allergen. So that we intend to measure. We do not have the facility as of yet. There is a ratio between the specific IgE and the specific IgG4. What happens in IgG4 disease is the total IgG4 which increases tremendously because of the multiple triggers and epitopes causing the rise. So that's the thing, and the presentation will be quite different.
Yeah. So that is the thing, I think, when we are dealing with IgG4, and I think Rafri madam was there. So if it is something which is abnormal, IgG4 total as we are doing in our lab, so we also need to be send some red signal that we need to be cautious and check for any other coexisting symptoms which can need to be done for ruling out the IgG4 related disease. Now coming to the management perspective, I think Dr. Kartik Nagaraju is there. You also telling about the atopic march and atopic dance. So if I'm seeing one patient who is a 8-year-old boy, now having some allergic rhinitis symptoms, it could be mild, persistent allergic rhinitis, family history positive. So what will be your take? Will you start allergen immunotherapy in this case?
So there must be reason. There is a reason why even the symptoms are mild and the persistence. There is a reason why they are presented to the physician, because they want a relief of their symptoms, which is not complete there. So there is a unmatched. Their expectation and the patient's reality are currently not matched. So we have to look at that also when taking into history, even though it is, like how you said, mild and only persistent. In such a situation, yes, we'll have to look at optimizing pharmacotherapy first, and if still after pharmacotherapy patient's quality of life or the symptoms are not improving, especially in a persistent scenario, or if the patient is having a tendency to proceed further for new sensitizations or develop a lower airway involvement because of strong family history or prior history of any eczema, and therefore this patient can have it. So in such situations, yes, further evaluation will be required with the target of first identifying any avoidable antigens, allergens, and then maybe if symptoms are persistent on optimal pharmacotherapy, then in mild persistent cases, it is usually recommended only if there is a failure of pharmacotherapy or if persistent symptoms are there despite pharmacotherapy, by which time they've already progressed to a little bit on the moderate side. So we always wait before we start or evaluating them further. So it is always about reassuring, just identify allergens which can be avoided, especially something like a cat or a pet if it is there, or if it's something like a mold which can be easily treated or avoided. That would be a scenario where I would want to get tested, but I would wait before evaluating them because if I'm going to evaluate further, the next question is going to be, do I need to start immunotherapy for this? Because as per recommendations also, it is only in the moderate and severe persistent allergic rhinitis that is the recommended indication for starting immunotherapy. And only if the family wants, I want a disease progression to be arrested, or I want to prevent new sensitization, or I want to prevent asthma from developing, then I want to take it. Only in such conditions I will further work up for immunotherapy purposes.
Yeah, so I think this is very important, and that is why when we talk about allergen immunotherapy initiation, the shared decision making is something which often often discussed. But as we also being taught about the allergen immunotherapy works always best when the disease is in mild form, disease in its early stage, and we need to stop the progression. So there the allergen immunotherapy will work best. But from that perspective, why we should wait until the disease will progress and it will develop some asthma or like that? So in that context, if you want to say something.
Yeah, so like I said, we have to explain the possibilities and explain that, okay, your sensitization is there is a chance that this will progress further, and therefore you want to arrest therapy, this is the ideal time to start immunotherapy, can be discussed with the family, but you're looking at utilizing certain resources, and how well are we going to utilize these resources for a patient who is having moderate to severe persistent asthma. And between mild persistent, moderate severe, I would choose for a patient who is having moderate severe persistent asthma to target with allergen immunotherapy 1. Second thing is, this patient takes immunotherapy, does not respond or stops because he is feeling better. He gives a false information also, like, okay, you take for 6 months, you feel better, therefore you also are okay. But again, at the end of the day, we have to know that for disease modifying point of view, after detailed discussion, only if the family is requiring, I tend to counsel them for immunotherapy in a mild persistent allergic rhinitis patient.
Yeah, so that's a take-home message, I think, what Dr. Karthik has said. I think we are at the end of our panel discussion, but I want your involvement. If you want, yes, if you, madam, if you want to ask something, yes, please. The mic.
What is your so I see that there is this atopic march and run and dance. So there is some sort of a redundancy, some sort of a master switch, if you will, some sort of a target that induces certain patients to progress towards the other disease phenotype. So what would be your comment on that? I know I'm an immunologist, and like I said, we are more into target and marker and patterns and pathogenesis. But even as clinicians, what would be your comment on which areas to look at? For example, all these the stalls outside, they are working on management of the inflammation, of the allergy. There is certain amount of degeneration setting in, which is switching on something else, which makes the disease phenotype, change into subtly something. So there is the skin part, there is the lung part, and there is the gut part. And if I'm too technical, please stop me. but there are the developmental aspects of ectodermal and endodermal development, which also affects the cellscape, which affects the pathological outcome. So I would like to know from clinicians present here, because you are all allergists, how would you go about looking for possible targets that expedites in a system network sort of a way that the probability of one degenerating into the other or not. So we are talking about targets which are switched on or off. We are talking about a threshold, crossing or not, which makes the disease progress into the other phenotype. What would be your comment on that? How to look for those targets, possible areas, hotspots?
So just to make sure that I have an understanding of the question, you're saying that what would be a way in which we can prevent other organ involvement if there is an involvement of one particular organ system further worsening, or are we talking about it from prevent? The way I understood it was, are there any preventive strategies available for such?
My question would more be in the realm of what would be the possible targets, cellular targets or molecular targets. So hotspots in systems biology. So it's a network of different signals happening. So some worsens, some doesn't. So a threshold has to be crossed in terms of the number of events happening, so that in the event horizon, my question to the clinicians would be, what are those likely hotspots where basic scientists can look at to understand that these are sort of the master switches that are getting turned on or off, and something can be done about it. So how would we go about looking for that?
I'm more of a clinician, I'll stay safe in the answer for now.
Still your ideas.
I think Madam was mentioning about the Th2 mediated pathway, the cytokines, where we can target. So if we talk about Th2 mediated pathways, yes, we can target those interleukin 4, interleukin 5, interleukin 13. And I think there are biologics also. We have one very good talk by Dr. Karthik also in this morning about the biologics and where we can target those. And apart from that, now the studies are ongoing that how we can go to the epithelium or further like the antigen presenting cells or even the innate lymphoid cells, ILC2. So I think this game is very complex in nature, and in one side we have the Th2 mediated pathway. Now the asthma management, I think we also have some sort of searching in Th1 mediated asthma. There are biologics that in developmental strategies. There are certain risks also if we nurture the Th1 mediated regions, because in different rheumatological conditions we use different biologics which modulate Th1 mediated reactions. But at the same time, I think in the lunchtime we were talking about Th17 mediated pathways, and if we modulate Th17 mediated pathways, there are certain again risk of autoimmunity. So there are lots of biomarkers in this game, and I think we have Professor Shoibal Moitra sir also. Sir is a clinician, immunologist, researcher. So sir, can you have some expert opinion in this?
I think Madam raised a very interesting question, and if we get to understand that the master cell or the master switch, then maybe it will be able to can solve most of the problems. Like a few years back, we used to think that whatever is being done is the master cell, is the T lymphocytes. Okay? But now we know the domain has shifted towards the innate immune system rather than the adaptive. Because it is the innate one which gives the signals to how the adaptive system will work. And as Shampo has very rightly said, and the innate immune system also, if we go more upstream, which is epithelial signaling, which is very important, how it will shape the antigen-presenting cells, the milieu in the antigen-presenting cells, and how they will behave and what information they will carry to the adaptive cells. And that the epithelial cells, we know they are in the host, they are one of the master intriguers, but their activity is also further modulated by the microbiota.
Yeah.
Okay.
Yes.
So this is very interesting.
Yes.
So maybe it's not only the disease that we're talking about. It may be the other factors from around which is actually triggering a particular disease state in a particular individual, and how that individual will behave, whether they will progress in atopic march or they will just go into the resolution of the disease. It's very, very important to understand the habits, the exposomes, the microbiota, and the epithelial cells.
Yes, so as in the morning also you were discussing about the gut-lung axis. Sir was mentioning about microbiota. So this is a very complex. We can do some collaborative work definitely in this field.
এখানে আমি just বলে রাখি যে এখানে শুধু মানুষের রোগ নিয়ে কথা হচ্ছে. We are talking only about human diseases, but as basic scientists, my PhD researcher who gave the talk in the morning, he's working on planaria. So these are diploblastic organisms, and we use that to understand the relationship between cells, between master genes, the transcriptome, if you will, because we are talking in a systems approach, which leads to wound healing. So the lesions are also a very important part of what is ongoing. So this is just a comment that planaria is it's a small 2 millimeter sea-dwelling creature, which we are using as models to unravel some of these mysteries.
Yes. So thank you, madam. I think we are at the end of the panel discussion, but as we are talking about allergen immunotherapy, and we in morning we had a lot of discussion about subcutaneous immunotherapy and allergen immunotherapy, but SLIT, sublingual immunotherapy, which we were using in the past, not that much discussed. So I have my friend Dr. Manoj Singh Burman here. So Dr. Manoj, I think you are also working with some sublingual immunotherapy. So can you tell us about some recent evidences on sublingual immunotherapy to this gathering, and then we can move forward. There is one mic.
Good evening, everybody. I am Dr. Manoj. Good evening, everybody. I am Dr. Manoj. I am medical advisor, Dr. Reddy's. Is it audible? Hello. I am Dr. Manoj. I am medical advisor, Dr. Reddy's. Okay, good evening. I am medical advisor from Dr. Reddy's. I did my MBBS from Ajikar and MD from Maulana Azad Delhi. So we are talking about a molecule called Recurrent. It will be launched as Sensium. So regarding SCIT, there is more than 100 years of evidence, but SLIT is probably 3 decades evidence. So multiple articles has been published where you can say that with respect to the efficacy, it's more or less comparable, but it's more safe with respect to your SCIT therapies. As well as the compliance of the patients would be high when you compare with that with respect to the SCIT therapies also. Any questions?
Yeah, so I think you had talked about more, but I think Professor Shoibal Moitu sir is also there. We had conducted one systematic review and meta-analysis, and where we found that SCIT and SLIT, the diamond is, regarding the safety also, the diamond is in the middle.
Right.
We cannot comment that is, from that particular systematic review meta-analysis, we cannot comment that yes, the anaphylaxis are more in SCIT. Yes, theoretically there is a possibility, but at least our meta-analysis had shown that there is no extra benefit in terms of safety. But you had mentioned about the compliance as we are talking about sublingual versus subcutaneous. But I think Professor Moitu sir may correct me in one of the study that had suggested that had done the 1.5 year compliance study, SCIT versus SLIT. In the SCIT arm, the compliance was 23%. We need to acknowledge the allergen immunotherapy when we talk adherence is much lesser than all the traditional treatments. In the SCIT arm, the compliance was 23%, or rather I can say, I use that terminology adherence here. But the SLIT arm, the adherence was much lower, only 3%. So that is something we need to again explore why cost will be also another important factor. So what is
one could be the cost reason. Second, we could say is that depending on the geographical location of the patient. Now, if the patient is from the metropolitan region, their SCIT could be sustainable. But say somebody is coming from a suburbs, or say somebody is 150 kilometers away and he has to come and visit your clinic every week twice. So in those cases, it will be more ample that you can offer them a SLIT therapy. That is one. Second is that whose quality of life is very much compromised, say for the schooling purpose or in the job profile, or somebody who has a regular travel or has to go on a regular driving. In that cases also, it will be more helpful in those conditions. And SLIT, standardized SLIT is very much relatively new, and even in India also, whatever I have gathered, standardization is less. And one advantage of that is that if you call a patient every month or every 2 months, the compliance is usually more. But if you say that you can come after 6 months, the compliance may decrease because the efficacy of immunotherapy can be seen after 14-15 weeks, 8 to 14 weeks, depending on the severity of the conditions.
Another issue I think while we are talking about SLIT, that is in SCIT we want a building up period. Maybe it is 6 months or 9 months like that. That building up, after building up period, we continue the maintenance dosing. But for SLIT, it is the very fast day from when we are actually using the maintenance dose.
Right. Means one concept is that the cumulative doses of an immunotherapy or an allergen. Now, in a SCIT therapy, we can up dose. Okay, either in the number of duration, or I can, depending on the response of the patient as well as the severity, I can either decrease sleep. But when it is a standardized or when it is a tablet form, which I'm dealing about, there the molecule is there. So the advantages of how benefit it will be to the therapy is that how the cumulative dose of the immunotherapy, as well as the duration of the therapy, as well as how early it is started, as well as lower involvement of the lower immune, decreased involvement of the lower immune. Means all these criteria will fit whether the immunotherapy is successful or not. But yes, I agree that the dose is fixed. Whereas if I want to elevate the patient to a certain level, with SCIT I can increase it very fast.
Yeah. So may I ask Dr. Karthik, because if you can tell us your experience with SLIT.
Yeah, so I personally, when I use subcutaneous and subliminal immunotherapy, there is a build-up phase where we slowly increase the dilutions, concentration. So with the anticipated theoretical possibility of avoiding systemic reactions with a higher dose in the beginning. But if you look at, a lot depends on the product, what quality, what is the antigen available, how much, what is the potency, what is the immunogenicity and allergenicity of this particular product, how much of them are available. So if you look at it, most recommended situations are where we don't have an idea of how much quantity or natural extracts are used for producing these particular molecules. You go ahead with build-up phase because we don't know, and that has stood the test of time for more than 100 years. But the one difference is the product that Dr. Manoj was talking about was actually, they found in their study that even at a higher dose, they were still able to stimulate the dendritic cells and the innate lymphoid cells earlier, and they were able to switch from a TH2 to TH1 even without requiring a build-up phase. The difference is intellectual property and the research methodologies they've used and the different products they've used, that's all. So if you don't use natural extracts like how we're having in India, you might have to go ahead with the time standard tested method of using a build-up phase. But if there is a product which there is evidence with randomized control trials where they have proven effectively that you can start without even a build-up phase in certain products, only that product you can start with without a build-up phase. But with other products, it would still be recommended to go with what our experiences will be.
Thank you, Dr. Nagaraju. So, take-home message from Dr. Athri Rai Choudhury.
So the take-home message from my end, from the laboratory part is, if we are going ahead with total IgE serial monitoring, we must do it from one lab, and if we have good communication with the lab people, we can also mention that this was the earlier report, so that we can get it done by the same method, because at times multiple platforms may be available for testing the total IgE. So it is very important to get previous report as well as adequate history. And another thing is for all the lab tests related to allergy and as well as for the general test, patient preparation is very important, and it is also our request to the clinicians to discuss with the lab so that we can communicate regarding the required patient preparations in order to avoid the pre-analytical errors and confusions in the later part. And when testing for total IgG4, it is paramount importance that we go ahead with the ratio rather than the absolute value. And as Mr. Goswami has pointed out, once we start using specific IgG4, I hope it will be more helpful for specific results that would help in the clinical decision making and also for better understanding of the patient, because it's important that the patient understands what is happening with his treatment. If they see that total IgE is rising but the symptoms are decreasing, so it becomes difficult. So for betterment of the patient, adherence to treatment and their adherence to the repeat visits as advised by the doctor is very important. So that is why it is important that the patient understands where his treatment is leading him. So for that, I hope specific IgG4, once we start testing it, that would be helpful.
Thank you, madam. Any small message from Dr. Karthik?
Yeah, again, as a clinician, I think history is the most important. We need to learn to take a long time in taking histories and not hesitate to revisit history where necessary with results. Always correlate whatever findings we have with regards to history, and even after starting treatment again, don't hesitate to revisit history if there is inadequate response anticipated.
Thank you, Dr. Nagaraju. So we had started today's panel discussion with history, and again we end today's panel discussion with again history only. So we now understand why one of my teacher, I think many of your teachers also, Professor P.K. Vedantan sir, always tell 3 things is important in allergy management for diagnosis. Number 1 is history taking, number 2 is history taking, and number 3 is also history taking. So thank you again, Dr. Athuri Rai Choudhury and Dr. Karthik Nagaraju. I am specifically thankful to Dr. Karthik Nagaraju because he was there from the very morning. He was there in the first lecture, and now in the second lecture also he had given, now the panel discussion. So I request Dr. Athuri Rai Choudhury to stay with us for this particular session, which is going to be started as a chairperson. We are really honored to have you as a chair for the next session, which will be a very interesting one. And along with Dr. Athuri Rai Choudhury, it is our real pleasure to invite on dais Dr. Saurabh Das as chairperson. Dr. Saurabh Das is a senior allergist in Allergy Asthma Treatment Center, Moulali. So may I invite Dr. Saurabh Das. And I think now all the chairpersons are Archie-Korean, and many of the, myself also Archie-Korean, so this is an Archie-Core dominant zone, and there are certain more speakers who is going to speak, they will be also Archie-Korean. So over to our respected chairperson. Just only one changes that happened in the session, that Dr. Devraj Josh had delivered his talk in the morning instead of our esteemed Professor Shoibal Moitra sir. So now in his place, Professor Shoibal Moitra sir will speak. So I am requesting you to carry forward the session. Over to Dr. Athuri, Madam, and Saurabh.
काटला मैंने कीप चेंज करो
A very good afternoon to all. So, respected chairpersons and my dear initiated 13 years back. So we know that this platform was initiated so that there could be an optimum discussion and sharing of knowledge between the basic scientists and the clinicians, so that it serves as a melting pot where we can all come together, share our ideas, which is definitely going to translate into better patient management and care. So that was the main idea of starting this Allercon 13 years back. I still remember my mentor, Professor Nirmal Chandra, who actually seeded this idea that this should be the case in India as well, so that this allergy domain can improve in a much better way in which it is being done in the Western countries. Well, so my entire talk and everything is dedicated to Professor Chandra. Yeah. So today I'll be talking about some of the perspectives of the allergen immunotherapy. I know you had an extensive talks on the AIT in the morning sessions. So my job would be to see that where we stand now and what are the future perspectives of the AIT, which is going all around the world. So this is just a glimpse of where we are standing and what potential this method of the treatment has for all of us. So I have nothing to declare in relation to this talk. Now if you see this is the tree of the development of the AIT. So let me start with 1911, when Leonard Noon, he first gave the allergen immunotherapy, the vaccines to treat the grass pollen allergic patients. And so that was an anecdotal observation. And the journey began from there. So from there, you can see, anyway, so from there you can see that how it just improved and went into leaps and bounds to where we are standing today. So we had more and more of the evidences. We have evidence-based medicine in relation to the AIT. And along with that, we had various position papers, we had various guidelines. So we had YACI guidelines, WHO guidelines, WHO guidelines, and which has actually paved and streamlined the way in which the allergen immunotherapy is practiced today all over the world. So this is how it began, and this is where we are now. Okay, so if you see this is a very interesting study which was published in Allergy in 2017. So what the investigators have noted is what was the path of the allergen immunotherapy. You see that it started from a standardization of the allergens, which we all talk about so much, that we need to standardize allergens, standardized dosages. Why? Because we know that what is the exact amount of the allergen we are giving to the patient in each dose. So now with the advent of this sublingual immunotherapy that we have just heard from Dr. Manoj, we know that what is the exact dose of the allergen being given per tablets to the patient. Now that is important. Why it's important? Because then we know that what is actually going, so we can have a dose-response relationships, and also we can understand the various side effects which an allergen can cause. But apart from saying that, a very important aspect is, does the non-standardized allergens have no effect? Well, if you see the past 111 years of the AIT development all over the world, it really underpins the basic fact that AIT, whether in the standardized or the non-standardized form, it definitely has an impact on the disease progression, quality of life, and the control of the symptoms per se. So that means it went into the double-blind placebo-controlled trials. We have sentinel trials related to AIT. Then we have a sustained effect, which we call a tolerance, development of the immune tolerance in the patient. So no other treatment, so no other pharmacotherapy or even allergen avoidance can bring about this sustained tolerance in the patients who are undergoing the AIT other than any other treatment form. So this is one very unique treatment. Okay, so then we had the disease modifying effect of the AIT. We had then the relation to the asthma, the food allergy and the multiple allergies. A very interesting thing, if you see, I'm not in detail, is the asthma prevention trials. That is the prevention of asthma treatment trial, PAT trial, or the Grazex asthma prevention trial, the GAP trial. Why this PAT and GAP trial? PAT and GAP trial was basically meant to understand whether, as we had just heard in the discussion, as Dr. Karthik was alluding to, that if a patient comes to us on an allergic rhinitis, we know that allergy is going to progress and it is going to take the form of some other disease, maybe an asthma, which we all fear about. And taking the change in environmental conditions in which we are living, we now know that there is an epidemic of the allergic disease all over the world. So in our country, we are seeing the epidemic is in the phase of the aeroallergens, or the allergic disease of the airways. But in the West, we have the food allergy epidemic, which is now there to speak. So can something be done in the very early stage, which can actually going to prevent the development of asthma later on by actually modulating the pathways of the allergic disease? Was basically the idea for this GAP trial and the PAT trial. Well, the initial results are not very encouraging. That is, they showed that, well, it does not prevent asthma, but it prevents one thing. It prevented severe form of the asthma. But recently, the extension phase of the GAP trial, now they're finding out that yes, it prevents asthma in a subset of the patients. Now, who are this subset of the patients in whom it is prevented? That's a big question. Therein comes the personalized treatment or the omics, which gives more idea about that. Okay. So this is the workshop which goes for a few years. It is the future of the allergists and the specific immunotherapy workshop. The last one took place in Hamburg in Germany. They have raised up these few very interesting points in that workshop. Now they've collaborated with the IAPI. Is what is there's a need for the biomarkers. We need to know that how we are treating our patients, whether they're improving, is it only that the combined medication and the symptom score, or we really need to have some biomarkers which is going to tell us that these are the patients who are improving on the AIT, these are the patients who are not. So because it's a story of the 3 years minimum, you understand that, so we need to have some at least numbers which is going to tell us and the patients together that yes, it's working in you. That's number one. So this was one of the major area of discussion in the FACIT workshop. Next was the future AIT pathways. What are the future? Okay, because no one wants to take the injections for 3 years or maybe for the 5 years. Then what is the future? How we can make this treatment more and more personalized, one thing. And second thing is that less and less painful. Okay. So, well, we have just listened about the sublingual immunotherapy. That is one of the ways in which it's more safe, less painful, more acceptable to the patients. But the big question remains, Dr. Manoj, is that of the adherence. Okay. Because we know what is the adherence of the inhalers among our patients? So, any idea? Shampoo? Much less than that. Okay, it is improving, but you take as the all over population as a whole. But what happens is normal nature. If the treatment is unsupervised and the patient becomes better, they will invariably stop. Okay, so now we have to think about the modalities, how we can improve the adherence of the treatment. It's not a per protocol analysis. It's not a study. Okay, neither intention to do well. It's a real world scenario. Okay, so that means in the 3 years, how many patients adhering to it? Because the world data set is 7%. Okay, and God knows what will be in India. Okay, taking the mindset of the people we deal with, and also this is all our mindset also same. We share the same mindset. Okay, we are no different from our patients. So it's very important to understand that how we can put adherence. So what and whether there are any shorter mechanisms. Okay, audible. So that is one thing. So can we just shorten the AIT? So that is one of the future areas, or we can improve in terms of the safety and the efficacy of the AIT. This was one of the part which has been discussed. So my entire talk would be based on the snippets of this FACIT workshop in 2019, because it is going to throw the lights of where the AIT is heading to. Then AIT and asthma, it's really a breakthrough. Whether it can control the asthma, it can take the patients out of the medicines, and whether it can lead on to the patients to that term which everybody wants to hear is cure, okay, which we do not have yet for the asthma. And definitely what are the regulatory prerequisites? We need to know what are regulatory prerequisites in our country, so that we can safely and under the regulatory acts we can give the patient this treatment so that we are safe and we are protected and within this network. And obviously there needs to be a harmonization of the clinical trial designs. There's a lack of the harmonization of clinical trial designs. So when you are doing a systematic review or a meta-analysis, you find the I-squared score is so high. Okay, so well, why? It's because of lack of harmonization about the what you are giving, how long you are giving, and what frequency you are giving, dose and all the patients. So there has to be a harmonized protocol of the clinical trial designs and also the monitoring of the clinical trials. And well, this is a very new thing about the allergen exposure chambers, which is coming up in the AIT trials, specifically in relation to the aeroallergens. So this is being, well, we do not have AEC in India at all. We have only 7 or 8 all over the world. But this shows a very important light about the real world scenario when they're exposed to that allergen, how the patient's airway behaves. So incorporation of the AEC, that is the airway exposure, allergy exposure chambers in the AIT protocol or the AIT trials is coming up in a big way. So I'm not going to detail of this slide. You already know it. Just few points that when we are giving the allergen immunotherapy, we know that while we are giving immunotherapy, this treatment is basically meant to make tolerance. By allergy is a broken tolerance, like the autoimmune disease. All the treatment is to remake that broken tolerance. Okay, so how we remake that broken tolerance? Remaking the broken tolerance entails the development of the regulatory phenotypes of the various cells, whether it is a T cell compartment or the B cell compartment or the dendritic cell compartment or the innate lymphoid cell compartment. In whatever compartment we are talking about, remaking of the tolerance is because having a regulatory phenotypes of these compartments so that the tissue homeostasis is maintained. And second thing is that we do not unnecessarily react to the allergens in whom the patient is not supposed to react. Okay, so this is what we know, that the dendritic cells releasing these cytokines, IL-10, 12, 27, and making the breaks, tregs, and the deviation from the Th2, Th1, and all the stuffs, which actually leads on to the development of the blocking antibodies, namely IgG4 or IgA1 or A2, which is important to make this tolerance. Okay, so we have known that the AIT can act at various levels, like it could be a reduced frequency of the Th2 memory cells. We all know the increased mucosal IL-10 and TGF-beta mRNA cells. Now, which are these cells? Now we know there's a regulatory phenotype of the innate lymphoid cell, ILC2, and all these cells are extremely plastic in their way in which how they react. So at one time, in one situation, they may be behaving as an inflammatory phenotype, and maybe given another situation, they behave like a regulatory phenotype. And in what way they will behave, it's just like say I am there, like talking to you people, giving a lecture, and so it's like this. It's a controlled environment. Maybe I go out in a market, somebody steals my thing, and I'm behaving in a separate way. So it's a plasticity. It's a way how which I behave is actually dictated by the environment in which I am in. The same thing holds for all these cells. It is the environment or the microenvironment in which the cell is. It dictates how it will behave. So if we change the environment and making it more conducive towards a tolerant environment, they will become tolerant. We won't have allergy, or for that matter, maybe autoimmune diseases. So this is the basic principle which goes in the AIT. And then increase mucosal interferon gamma cells, which is a signature cytokine of the Th1 cells, or maybe IgE blocking antibodies, namely IgG4, or reduce mucosal mast cell infiltration, because the mast cells, we know they are basically the cells which are actually in direct communication with the environment and takes the signals and sends it to the other cells' adaptive immune system. Not only the cells' adaptive immune system, but even the neurons as well. So we're discussing that, yesterday there was in Mumbai and Karthik was there. That's a new thing of the psychoneuroimmunology where mast cells plays a very important role in that also. So anyway, so this is the thing, this slide you must have seen several number of times. That is, as we move forward towards the AIT, there is very early basophil activation is reduced very early in the treatment. Then later on there is decrease in the type 1 reactivity, there is increase in the blocking antibodies, reduction in the IgE cells and so on and so forth. But interesting, only one point here I would like you to focus is that there is a shift from the Th2 to the TREG. It usually does not occur before 3 to 6 months. So maybe the optimum time is the 1 year if the patient is having a successful AIT. So that means this 1 year is what? This 1 year is usually it says it is from the maintenance effective dose. So effective dose 1 year you get this shift, and this effective dose that can, or the maintenance dose can start maybe 6 months down the line of starting the treatment if your build-up phase is conventional, or if your more rapid build-up phases like the cluster or the rush or the ultra rush, it can come early. And in the sublingual slit, it usually comes earlier because we are able to give a much higher dose from the beginning because it is more safe for the patients. So this is the important thing. So this crossover from the Th2 to the TREG is a very important component which we all need to want for the patient for them to come out of the allergy. And this is how it goes, like what we see initially when there is a Th2 dominance, over a period of 1 year later on, it becomes a more of the TREG mediated or the regulatory mediated pathways. So we understand one thing very well from this is that whatever the biomarkers we talk about, we should have the biomarkers which will tell us whether the patient is becoming more tolerant or not. So that means, what are they? It could be interleukin 10, it could be a specific IgE to specific IgG4 ratio as Dr. Athre was just talking about, or it could be simply specific IgA1 or specific IgA2 or things like that. There are so many biomarkers in the pipeline, or there could be some metabolomic biomarkers in the form of the sphingosine, in the form of the creatinine, in the form of lactic acid, and so on and so forth. So now see what's the newer developments in the AIT. If you find that the newer developments, mainly I'm not talking about the adjuvants because there are lots of work being done on the adjuvants which can improve the efficacy of the AIT. So there could be some good adjuvants like in the form of the CPG motifs, or there could be the other adjuvants. Hence we go from the traditional alums and all, or there could be allergoids. We had allergoids in the Indian market for some period of time, and they have taken it off, and we have seen that this hypoallergenic these molecules, they definitely work very well and they're quite safe. But apart from that, we need to see that what are the modifications has been done in the form of the route in which they're given. So whether it is an intralymphatic immunotherapy, whether it is an oral immunotherapy, whether it is a sublingual immunotherapy. So this is the SCIT. This is, apart from SCIT, we have the ILIT, we have the OIT, we have the EPIT and all those stuff. But very important to understand what are the clinical outcomes we are considering. One is the reduction in the medication scores, reduction in the symptoms, but very important is improvement in the quality of life along with the reduction in the allergen reactivity. So these are all the metrics which is considered while we're evaluating a patient of the allergen immunotherapy, and these are the areas where the newer developments are taking place so that we get hold of the better ways, modalities of the treatment of the allergic disease. So what are the novel approaches we have? It could be a peptide immunotherapy, like these are the T cell epitopes which the patient is given so that they do not form allergy. So they are not a B cell epitope, the T cell epitopes, so that means they will have the immunogenic, but they are not allergenic. Or it could be a contiguous overlapping peptides. Usually they have the 40 to the 70 peptides, and mostly they help in mounting the response, immunogenic response, much faster than that of the conventional AIT. Or it could be intralymphatic, or it could be epicutaneous, these are the roots, or recombinant allergens. So the recombinant allergen means because of the recombinant technology, we have the allergens, they are modified in a way so that the T cell recognizes it and generates an immune response towards it, but reducing the IgE responses, and hence the various allergic side effects, including anaphylaxis from the allergen. So this is the molecular AIT, the domain of the molecular AIT, which is being developed all over the world, and this is the future. Okay, so it could be only a T cell epitope containing peptides, or could be recombinant hypoallergen, or very interestingly, the virus-like particle, that is the VLP coupled allergen. Now we have the virus-like nanoparticles, okay, and they have been combined with the cat allergens for the cat immunotherapy. Why? Because they makes it more immunogenic. They helps in the development of a Th1 and response. But the problem is that if a patient already has an antibodies to that virus capsule, that usually causes it ineffective because it destroys the virus-like particles. So now more research is there so that body accepts it, does not neutralizes it, and at the same time the allergen is coupled. So there can be two things. The allergen is coupled with the virus-like particles, or you give both simultaneously. So these are the various ways in which it is being done. Or it could be a recombinant allergen-specific IgG blocking antibodies, or maybe the allergen encoding nucleic acid. So the DNA vaccines of the allergens, which is coming up, it usually says that it will only have the DNA encoding of the part of the allergens where it can lead on to a robust T cell response and not an IgE response. So this will make them more immune. So these are all the various ways in which the AIT is being developed all over the world. So this leads to a very important area of recombinant allergens and AIT. You can see that this is for a typical grass pollen allergens. So we have the conventional subcutaneous AIT where there is a build-up phase, then there is a maintenance phase. But in the recombinant scheme, we do not need the build-up phase. Why do we need the build-up phase? We need the build-up phase because we cannot reach the maintenance phase from the first injection, otherwise the patient will have a severe chance of having severe anaphylactic reactions. It cannot. So body needs to get tolerant to it. But if we have a recombinant allergen where there is no chance or very little chance of having anaphylaxis, we can straight away go to the effective dose or the maintenance dose, and that is usually done by the pre-seasonal immunotherapy in the grass pollen allergic patients. It's been tried in the birch pollen allergy, and this recombinant has this AIT has been very, very successful in the studies which are shown. Intralymphatic, you all know, it's 3 injections, 1 month apart, and that does the thing. And so when 3 years has come down to the 3 months, well, we do not have intralymphatic preparation for the many. We need an alum preparation for that. We did an ultrasound and expertise for it. It has been evaluated all over the world, and maybe the next 1 or 2 years we may have the facility in India as well. This is a very novel thing. Epicutaneous, but it had been there before also. So the important thing is that you are actually using the Langerhans cells to actually develop the tolerance. And this is important is that this big role is coming up in the food allergic patients, okay, because this is the OIT, now more and more epicutaneous immunotherapy is being used for the food allergens in those who present with that. So they usually have a tape, and the patients just have the tape on the skin, and where the allergens goes into the skin, and usually the dendritic cells in the skin takes it up, presents it to the naive T cells, and it modulates the activity of the naive T cells to have a regulatory phenotype, and that's all it does. This one is a very interesting and futuristic study which was published. So it goes a way beyond, and maybe some kind of primordial prevention, it brings it up. So see what it does is that it's a very interesting study. And see, initially they first with the component diagnostics, they first see which are the components which actually causes the allergies and what is the spread of that component in the community. So if they say that if LD1 is very common in the community, cat allergy is quite common in the community, or for that matter maybe the WP1 or maybe WP2 or whatever it is. So what they do is that they just combine that allergen into a hypoallergenic state into a wild type folder. It means changed into a carrier protein and injected into the mother. So what the mother does is that the mother then produces the IgG response to it. Okay, and this IgG is recombinant hypoallergens, then the IgG produced, then can cross the placenta and go into the fetus. So what happens is that when prenatally there is a vaccination with the IgG polyclonal antibodies, and also this transmission of this monoclonal IgG antibodies into the fetus, so they are actually protected from developing the allergy before their birth. And postnatally also they receive few injections. So this both the prenatal and the postnatal injections makes them almost free for the allergy. This has been going on. Now this is the various birth cohorts who are working on this. So they will just see the children for the next 20 years or 25 years and see their development of the allergies in them. This is a very interesting thing. So this brings up to almost the end part of my talk, that is the personalized AIT. We all talk about the personalized medicine these days, but this is the time when we just come out, we try to come out with the blockbuster medicines. We do not want to give blockbuster medicines like the inhaled corticosteroids or for that matter the antihistamines and all. We want to precise our treatment. We want to give this treatment to that individual. A treatment for the same disease individual, B is different in a way so that we are more sure about the outcome of the treatment. That is the personalized AIT. This is a standard treatment, that is all the allergic patients, you do the skin test, you prepare the AIT, you give it to them, and you know that at some point later some of them will have effect, some of them won't have effect, but that you can know only after 1 year of reaching after the maintenance dose is reached. But the personalized medicine is based on the various biomarkers and the novel patient enrollment strategies. We have various stratified AITs for the various patients. And this stratified AIT, you just stratify it so that chances of having an effect is maximized and the chances of having no effect is minimized to near to zero. So this is how we go about that. As we do not have the early stopping rule, that when shall we stop the AIT in this patient, the patient is coming back with the symptoms, or if the patient is continuing and got the good results, how long should we continue? So that's why initially we have the phenotypes, which is going to decide that this is a patient, yes, we know this is a patient with allergic asthma, and he or she will be benefited from the AIT. But down the lane, if you know the endotypes, we know that this endotype will do whether they're IgE producers or whether they're eosinophilic asthma or things like that, and they will be benefited from this is AIT. And if they're non-eosinophilic, we say that this patient's endotype, they may not be benefited from the AIT and we stop it. But the late stopping rules, we have now serotypes. Serotypes means whether they're responders, they're super responders, or they do not respond at all, or they're mild to moderate responders. So there are various biomarkers to identify the serotypes of these patients, which will guide the late stopping rules. So as of now, standing today in this podium, we do not have very specific guidelines for the early and the late stopping rules, but there are going to be a Yaki position paper very soon. 2 has already come out. Next is going to come out this year, maybe in the later part of this year. We'll be having the early and the later stopping rules for the AIT, which is going to make our things easier. Okay.
Sir, we have reached our given time frame. So I request you to finish within some few minutes.
Yeah, so we have reached the conclusion slide. Thank you. So this is the various rules of the AIT that we have just talked about. So only the very near to our present situation, the epicutaneous immunotherapy, giving the biologicals like the omalizumab with the immunotherapy and the omalizumab for the multiple food allergies that we've seen in the OUtMATCH trial. But important to understand that biologicals do not change the biology of the disease, they can only reduce the symptoms. or we have the primary and the tertiary prevention of the allergy depending upon the various contexts of the patient in which we are seeing them. Thank you very much.
Thank you so much, sir, for a nice and elaborated presentation. I should ask from audience if there is any question or discussion. Sir, I have a personal question. When to stop if a patient on immunotherapy is not improving clinically? When to stop immunotherapy? At which point?
What we know now is that once you have reached the maintenance phase, okay, and you continue the maintenance phase for 1 year, and the patient is not improving, in the sense that patient is having more exacerbations, you are not able to reduce the symptoms, you are not able to reduce the medicines, that is the time you should think that it's not working in that patient and you stop the immunotherapy. That's what we know as of now. Okay.
Sir, is there any other option to redo the skin test and to change the vaccine means immunotherapy composition?
See, sure. The thing is that this actually this exercise should be done before, okay, embarking on immunotherapy. That is the right patient, the right allergen, the right dose, and obviously maybe the right duration. So right patient, right allergen, right dose, we decide the beginning of the therapy. But say it's down the lane you see that well, patient not responding. Obviously, you can again redo the entire thing. You can just take it a new look. So whether this was the right patient who was rightly started on the immunotherapy, this patient may not be the right patient. Or maybe this was not the right allergen. Or maybe that was not the right dose. A very important concept to understand at the juncture is that if the patient had spent the time and money with you for 1 year of the maintenance phase and still not improving, then again coercing the patient towards another immunotherapy means schedule, it's going to be some of a very Herculean task which usually we do not intend to take. So maybe these patients won't do good. If your selection was right at the beginning, they won't do good with it.
Yes, I agree with you. I welcome any question from our audience. Or shall we progress to the next? Okay.
Madam, can you take the question later because we'll take the question later.
Who is the next?
So we have now the next topic on breaking the cycle of recurrent urticaria, and we will be really honored to have Professor Sudeep Ghosh. Professor Sudeep Ghosh, currently the professor and head at the Department of Dermatology at Allercon Medical College. So welcome, sir. So sir will tell us about the difficulties and intricacies of urticaria management.
So good evening everybody. All of you must admit that urticaria is a burden to the patient, to their family members, to the society at large, and on the healthcare system. my respected teachers and their colleagues. Today, my topic of discussion is breaking the cycle of recurrent urticaria, a patient-centered approach. I have two disclaimers. Number one, I have no conflict of interest. And second one is I am a pure clinician, so I will concentrate on the clinical aspects in a patient with recurrent urticaria. And the objective of this present session is to provide a comprehensive overview about the different terminologies of urticaria, why recurrences occur in the setting of chronic urticaria. I will present a few case-based scenarios and I will give a comprehensive overview about how to break the cycles of urticaria. So back to the basics. What do we mean by urticaria? Urticaria is the development of wheal or angioedema or both. And why it is called acute? When the duration of urticaria is 6 weeks or less, it is called acute urticaria. Now, what do we mean by the term chronic urticaria? Chronic urticaria is a condition where urticarial lesion is present on daily or on almost daily basis for a period of more than 6 weeks. This is the latest classification of chronic urticaria, and you can appreciate that chronic urticaria can be broadly divided into two groups. One is chronic spontaneous urticaria and another one is inducible urticaria. Now, today's topic of discussion is recurrent urticaria. What do we mean by the term recurrence? A type of chronic urticaria that occurs intermittently over months or years, or when the urticaria is in remission, after that a few months or after complete resolution of symptoms and signs of urticaria, it can recur. When the control therapy was stopped, it is called recurrent urticaria. In different studies, it has been seen that near about 13% cases of urticaria usually presents with recurrence. Next. Now, what is the pathway while dealing a patient with urticaria? First of all, we have to know the pathogenic factors behind the chronic recurrent urticaria. A detailed history should be taken and a clinical examination is needed and appropriate investigations to be done to come to a precise etiology of the chronic urticaria. And after that only, we can provide general and specific pharmacological treatment to the patient. And if it works, there is adequate treatment response, no recurrence. But in some situation, there is inadequate treatment response, giving rise to recurrent urticaria. Now, while dealing with a case of recurrent urticaria, we have to introspect ourselves. Why? Whether we are missing something. Next. So, two situations can occur. Next. So, there may be faulty or inadequate diagnosis that can lead to recurrent urticaria. So, in this case, we have to reassess the history, examination and investigation part. Next. So, we have to find out whether there are any pathogenic factors that are missing, any physical triggers like cold urticaria, any trauma leading to dermographism, pressure urticaria, etc. Any pseudoallergens, particularly dietary pseudoallergens like salicylates, benzoate, etc. Any history of contact that can lead to urticaria while we are missing a case of chronic urticaria. Any particular drug history. Some drug can give rise to angioedema-like symptom, like AC inhibitor, like sartan, like gliptin. Any source of infection. Patient may have some features of chronic sinusitis, caries teeth, cholecystitis, etc. while discharge per vagina. So this chronic source of infection or chronic inflammation may lead to recurrence of urticaria. Any occupational history, occupational exposure can give rise to angioedema or urticaria-like symptom, particularly when the patient is using some vibrator in his workplace. It can give rise to angioedema-like symptom. Any other visible etiology, any underlying autoimmune connective tissue disease. And while whether we are missing some urticaria mimic. Some conditions may look like urticaria, but actually they are not urticaria. For example, urticarial vasculitis. And whether there is any syndromic association. So we have to reassess all these things to come to a specific etiological diagnosis of recurrent or chronic urticaria. So after the appropriate etiology is addressed, we can precisely treat the patient to improve the cause of recurrent urticaria. Next. So let us take some case scenarios. A 25-year-old man presented with recurrent episodes of urticaria for last 2 years, particularly over the forehead. Adequate dose of second generation antihistamine could not prevent the recurrence. You can appreciate the urticarial wheal over the forehead. And on repeated query, patient give history of application of tiger balm on his forehead to relieve pain. Routine investigation was non-contributed. So what may be the possibility here? We did a short contact patch testing. Next. Next. So open and semi-open short contact patch testing was done. The left panel is left one, which is not covered, is open, and that is covered with micropore. That is known as short contact patch test. And the reading should be done here after 30 minutes. And antihistamines should be stopped for at least 48 hours before doing the patch test. So here you can appreciate there is the arrow marked area. The reaction was positive, 2+ positive, according to international consensus guideline. It was 2+ positive to balsam of Peru. Next. So we searched the literature. British Society of Cutaneous Allergy, they showed that Pyroxylin periri is the scientific name of balsam of Peru, and it can be present in several things. Next. And you can appreciate next. Chinese balm or tiger balm may contain the component of Pyroxylin periri, that is balsam of Peru. So what we did next? So the final diagnosis was balsam of Peru induced contact urticaria. Tiger balm was stopped along with institution of antihistamine, and no recurrence in 6-month follow-up. The patient was also advised to avoid the other component that contains tiger balm. Another patient, the patient was referred to us 2 months ago from Pediatric department. The patient had recurrent urticarial episodes for last 8 months. No dyspigmentation, no history of exacerbation following cold exposure, and the patient was not adequately responded to conventional second generation H1 antihistamines. She was associated with high episodic fever, myalgia and ophthalmia. X-ray was within normal limit previously. And in association, the patient had mild sensorineural deafness. Patient had leukocytosis and markedly raised CRP. So what may be the possibility? The urticaria was recurrent and not responding to conventional mode of treatment. Next. So there is recurrence in spite of adequate dose of antihistamines, very high CRP. So we thought of possibility of CAPS, that is cryopyrin associated periodic syndrome. Patient had high CRP and urticaria like rash, cold induced aggravation, sensorineural deafness, ophthalmia and ophthitis. So it fulfills the criteria. Due to institutional non-availability and financial constraint, we cannot do the genetic testing. Next. Currently 3 anti-interleukin-1 treatments was available for this condition. Coming to third case. A 42-year-old woman having recurrent urticarial lesion over the abdomen and flanks. Particularly at the end of day, the lesion were aggravated. The condition was persisting for more than 8 months and not responded to conventional second generation H1 antihistamine in adequate dose. So what may be the possibility? Next. So we did a delayed pressure urticaria as the test. This is the test modified after Barlow. These two rods, they are usually placed over the thighs of the patient and reading was taken after near about 6 hours. And after 6 hours, there was positive result. So the final diagnosis was delayed pressure urticaria. Patient was advised to loosen the drawstring. Tablet levocetirizine 10 mg twice daily was given, and topical clobetasol propionate was also advised. There are some anecdotal reports of topical clobetasol propionate for delayed pressure urticaria, although it doesn't work in other cases of urticaria. And we have also prescribed colchicine, and patient showed good response. A 60-year-old retired serviceman presented with recurrent non-itchy articarial eruption, episodic fever, bone pain, and patient had cervical lymphadenopathy and mild splenomegaly. Neutrophilic leukocytosis, patient had mild anemia, ESR was, first hour ESR was 112 millimeter, and raised CRP. So in this background, in an elderly man, next, we did serum protein electrophoresis, and it showed M brand. So in an elderly patient with very high ESR, presence of bone pain, mild anemia, always think of Schindler's syndrome. Next. So this is a condition where paraproteinemia is associated with chronic urticaria. The obligate criteria is urticarial rash and monoclonal IgM or IgG on serum protein electrophoresis. And there are minor criteria like recurrent fever, bone pain, and a neutrophilic dermal infiltrate on skin biopsy, and elevated CRP and leukocytosis. Next. This is another interesting patient, a 9-year-old girl, recurrent swelling of lips, hands, feet, eyelids for almost 3 years. The photographs of different ages are shown here. You can appreciate there is angioedema of the hand, eyelids, and it was associated with mild pain but no pruritus. Occasional breathlessness and colicky abdominal pain was associated with the condition, and no history of preceding drug intake was there, and recurrence in spite of numerous courses of antihistamine. Next. We did C4 and it was low, and low C1 esterase. It was 36. The normal range was 195 to 345. Next. So you can appreciate the patient had low C4 and low C1 inhibitor esterase. So next, we did the final diagnosis. We stamped the patient as type 1 hereditary angioneuritic edema. Next. Next. So final diagnosis was type 1 hereditary angioneuritic edema. This patient, a 30-year-old female, presented with recurrent persistent urticaria-like lesion associated with burning sensation and pruritus. And after healing, usually the lesions persisted for more than 2 days and heals with slight hyperpigmentation. So considering the presentation, next, we did a histopathological examination which shows, next, previous one, subtle leukocytosis, and there is vessel wall degeneration, fibrinoid degeneration of the vessel wall, and mild papillary dermal edema. So actually the patient had leukocytoplastic vasculitis in the histopathological picture. Next. So the final diagnosis was urticarial vasculitis. So how to differentiate urticarial vasculitis and urticaria clinically? Urticarial vasculitis usually persists for more than 24 hours, usually heals with hyperpigmentation. On endoscopy, you can get some purpuric spots, and on histopathology, you can get subtle feature of small vessel vasculitis. So we treated the patient with levocetirizine, hydroxychloroquine, and short course of prednisolone. Next. So to summarize this portion, the appropriate, well, you can stamp the appropriate diagnosis, we can diagnose the patient precisely. We have to remove the triggers. We have to remove the physical triggers. We have to avoid dietary pseudoallergens. And in case of contact urticaria, the contact should be removed. Appropriate drug history should be taken and avoid culprit drugs and related drugs. Treat the source of infections as I have mentioned already. And other etiologies should be treated accordingly. Appropriate diagnosis and treatment of urticaria mimic like urticarial vasculitis is to be done. And in the syndromic association like autoinflammatory syndrome, we have to treat the condition accordingly.
Sir, 1 minute left.
Now coming to the next part. Next. If the treatment is inadequate, in that case, what we should do? Next. We have to assess the compliance. We have to assess the compliance. So non-compliance is a very important factor for recurrent urticaria. We have to check the dose, whether it is adequate or not. We have to look for the appropriate drug and whether the patient has stopped the drug prematurely. Next. To solve these issues, several guidelines have come up, like ACI guideline, next, Indian consensus and British guidelines are there. To summarize these guidelines, next, second generation antihistamine is the drug of choice for the treatment of urticaria, any type of urticaria like acute or chronic. And if there is no response, fourfold increase of the antihistamine can be done. We can add some H2 antihistamine like ranitidine or montelukast, particularly in the setting of angioedema. The second line is combination of antihistamine. A short course of systemic steroid can be given up to 10 days and appropriate therapy depending on etiology. The third line drug includes immunosuppressive therapy in the form of cyclosporin or systemic immunomodulator like omalizumab in appropriate doses. So the take-home message is that next, physical urticaria may be associated with recurrence much more in comparison to chronic spontaneous urticaria. Patients with no definite trigger factor, there is more chance of recurrence. Addressing the triggers are of utmost importance. Compliance should be assured. Dose should be adequate. Appropriate drug choice is very important. And proper timing of stoppage of treatment is also very important. And it is noteworthy that patients who need higher level of therapies are more prone to recurrence. Thank you. Thank you all for your patience.
Thank you very much, sir. We will take the questions after the next session. And now I'd like to invite Dr. Kollur Patro for his speech on pediatric allergic disorders, a multi-system challenge.
Good afternoon, all the delegates, my friend Sambu and my teacher Dr. Mitro. It is a privilege to speak in front of you. Today, a short case discussion and for that is little explanation of that. That is pediatric allergic disorders, a multi-system challenge. So here our case is a 5-year-old girl lives in Kolkata. She presented with cough mostly at night and in the morning for last 6 months. Sometimes vomits after cough and there is some whistling sound during breathing. She often have runny nose, sneezing, blocked nose, eye itching, some redness of eyes for 2.5 years, which is more during the weather changes, rainfall. The sneezing also mostly seen during after awakening from the bed and gradually subsides after 1 to 1.5 hours. She also has very dry skin with itch, which are itching, and sometimes there is oozing also, mostly over back of neck, elbow, back of knee joint, ankle, etc. It started from around the 6 to 7 months of age, initially very frequently, but now frequency and severity all reduced. From the other history, mother has asthma, that's why she is taking some inhaler. But mother couldn't explain what the medicine actually is. The vaccination status of the child is up to date as per national immunization schedule. Here one important thing, the influenza vaccination is usually not given. The father smokes and at home they use the mosquito repellent. There is no pets at home and they reside around 50 to 60 meters from the main road. So on clinical examination, we found a wheezing sound present over the chest, some patches of atopic dermatitis over ankle, back of the thigh, and her weight, her height was appropriate for her age, and all the other systems were within normal limit. She was taking syrup, montelukast and levocetirizine combination for a long time from his local pediatrician. And she was taken levosalbutamol inhaler several times due to this wheezing and cough, and some nasal spray, that is mometasone, was given around for 2 months. And due for those skin lesion, she usually used some moisturizer and sometimes some steroid, that is desonide, was given by the pediatrician. And here we can see the skin problems here over her heel. That is thick skin over her hand and over antecubital area, this lesions found. We did some investigation for the CBC, it was almost normal and there was nothing in chest x-ray. We did a FOT test where some bronchodilation seen and we did a CRD test for which the dust mite and cow milk was positive. So what was our diagnosis? Our diagnosis we made, that is asthma, some allergic rhinitis, there was atopic dermatitis and food allergy also. Because all from the history, we can find that from the history the nasal problem, the breathing problem and the skin lesion also. Though the asthma symptoms are usually diagnosed by clinically, we go through directly FOT test because the child couldn't perform the spirometry and it was suggestive of that. And we thought for skin test, but the child was on levocetirizine montelukast combination and she was not willing to for any prick test. That's why we directly go to the CRD test. So all this combination actually, this the diseases asthma, allergic rhinitis, atopic dermatitis and food allergy. We can see this is a spectrum of a disease in different manifestation from the different organ system. So we can say this is a atopic march, what usually a common term nowadays everybody knows. So what is the why this is? We will go after that. WHO actually says the allergy is the fourth most relevant disease by this time, and by 2050 more than 50% of all population will have one at least of this type of symptoms. The allergic march, that is atopic march, the natural course of the onset of allergic condition based on the concept of a single trajectory of a allergic disease progression, namely a linear sequence beginning with the atopic dermatitis and food allergy in the infancy and in the subsequent development during the childhood and adulthood of the respiratory allergies, that is the allergic asthma and allergic rhinitis. Here a graph that is showing some progression of different type of allergic disease, that is atopic march. The blue line, that is eczema, it is very early in the infancy. Then comes the red one, that food allergy. Then comes the green one, the asthma, and then the rhinitis component. But now we are going to the next slides that will show this actual classical picture may not find in all the cases. So the type 2 inflammation is a common characteristic several organ involved, mediated by a both innate and adaptive immune response. So this type of mix of manifestation may we get in the later line. Variability in the onset and progression. So we can see that the presentation may not be a sustained level. There may be some component is more than that of others. So there is a variability in as the age also and in the progression also. Then heterogeneous scenario does not follow the linear and single trajectory. Single trajectory, though we can get around 50% of pediatric population may have one or more allergic problems in several times, but multimorbidity is only around in 4 to 6% of in their adulthood. Okay, or we can say that very early before the adolescence also. In most cases, progression is not consecutive or at least not the same in all patients. What that is means, in most cases, the sequence of the events is not one by one, and in some patient this may be specific for them also. Here a picture showing in the infancy there may be huge, that is number 1. So we can see the large cycle in the left lower, that is the whole population with atopic dermatitis that may progress to another disease. That is from the 2, it can go to the directly asthma. From the 3, it can go to the atopic rhinitis, and from the 4, we can say it can go in bidirectional, that is asthma and atopic rhinitis. So the total population may not go to one direction. Some part of they may go one side and another side, and sometimes both in asthma and allergic rhinitis component. So there are some author has proposed several types of manifestation. One of the studies we have found there are 3 clearly differentiated allergic march endotypes. That is, number 1, there is allergic march or atopic march dominant type, where the genes related to the eosinophilic disorders were upregulated, while the airway epithelial barrier remains repair genes were silenced. In the second group, they found higher rate of asthma patient, where the genes related to the reactive organs, reactive oxygen species were upregulated, that is a pro-asthmatic signal. And in third group, that is the group with atopic dermatitis predominated, where the genes related to the extracellular matrix proteins were downregulated with increased circulating phosphatidylcholine levels. So in this, the 3 type of presentation, the manifestation were different. So all these things are dependent on several etiologies, that is epithelial barrier dysfunction. There is environmental factor, that is allergen, pollutants, irritants. Irritants may be some detergent, maybe some microplastics and all the surface cleaner, this type of things which can erode the skin. Then comes the microbiome. There is reduced microbial diversity. We can see in atopic dermatitis there is more chance of infection with Staph aureus. Then some genetic factors. some genes are targeted, that is FLG gene. There is loss of function, which is more for those with atopic dermatitis. There are some another genes, that is IL-2RA, GST-MP. Those immune cells are signaling molecules, and the epidermal differentiation are dependent on this. Then comes the KIF3A, IL-13. Those are more likely associated with atopic dermatitis and food allergy. Then comes the STAT6 and TSLP, which are most common in eosinophilic esophagitis. But there are also atopic dermatitis, food allergy, asthma, allergic rhinitis, all may be present. And there may be some immune dysregulation, that is Th2 immunodominance. There are some risk factors also, that is industrial or environmental exposure of pollutants. There may be polysensitization. There may be FLG mutation, already I have told that. There may be parental history. Here in this case the mother has asthma, for that the mother is taking the inhaler. The early onset, usually it has been seen when the atopic dermatitis is, if the onset is before 18 months of age, the chance is more. And the severe disease, it has also been seen when the atopic dermatitis, if the disease is mild variety, the future, this progression is less rather than when this is more severe. So in conclusion, we can say that the atopic march recognizes the increased occurrence of asthma, atopic rhinitis, or both after the AD onset. The mechanism of developing atopic comorbidities after the atopic dermatitis onset are poorly understood, because there are a lot of things. There is genetic factor, there are the environmental factors, and some pollution factor, all these things. This can involve the impaired cutaneous barrier, which causes more cutaneous sensitization. The systemic Th2 dominant immune response to cutaneous inflammation may driven or amplified in the susceptible subjects. And there are shared genetic loci, environmental triggers, that is microbial dysregulation with the temporal sequence. So the tissue-specific peak time of the occurrence of each disease that causes the clustering of the disorder, that rather than of a march. So in the last line, it is very important. In all the patient, particularly we see there is in different type, different systems are involved. That's why the different manifestation is present. So suppose in a patient, it may start with atopic dermatitis. In other patient, it may not be started with atopic dermatitis. In those patients, they may directly from the wheezing, that is under 5 week wheezing, then allergic rhinitis in future. But in some other patient, there may be only the wheezing, and then the atopic dermatitis developed after that. Some patients may present with esophagitis with pain abdomen recurrently. There may be some clear skin lesion or may not be. So this type of different manifestation may present. So in we can say that the atopic march may not be appropriate nowadays. It can go in a linear fashion, in non-linear fashion. It can, we can see it atopic dance or atopic run, whatever. But the concept of the atopic march may not be appropriate in all the situations. Thank you.
So thank you very much, Dr. Pal. Now we have come to the end of our session on case-based contemporary lectures. I'd like to ask the audience if there are any questions on the cases presented. Ma'am has some question, I think.
I may invite Professor Shoibal Mitra sir and Professor Shuripur sir on the dais.
একটুখানি ভুলে গেছি শৈবালবাবু। যতটুকু মনে পড়ছে আমার মানে অ্যালার্জিতে কাজের থেকে যে ডেনড্রিটিক সেল থেরাপি নিয়ে আপনারা কেউ কিছু বললেন না, সেটা কি খুব একটা এফিকেশিয়াস নয়? মানে এআইটি না, আমি যত ভাবছি তত আরও গুলিয়ে যাচ্ছে যে it's such a mess. There are so many things. অ্যান্টিজেন একটু একটু করে দেওয়া হচ্ছে, বি সেলদের মেমোরি তৈরি হচ্ছে ইত্যাদি। সেখানে গোড়ায় গলদ মানে ডেনড্রিটিক সেলগুলোকে ওইটাই প্রশ্ন।
Thank you, ma'am. So, what Madam which has raised is an interesting area of research nowadays. So, the dendritic cell therapy, which is still I would say has come into the clinical trial per se, because now what has happened is that the initial results have been very encouraging. But with the advent of the various other factors, there have been few trials which have shown some results which were not very encouraging. So, but maybe that because the trials were not harmonized, the studies were not harmonized totally. It is a very area, because as the signals are being sent from the outside wall to the adaptive cell by the dendritic cells. So if we can just change the dendritic cell in the way they send information, they're the postmans. So if you can just polarize them towards giving a regulatory signal, then whatever the signals comes from the outside wall, dendritic cell will take a specific signal. It's a very interesting area. I haven't alluded upon that, because in the AIT, the concept of the dendritic cell changes into regulatory phenotype is one of the burning issues which is there. But we do not have very good evidence per se from the clinical background, so that's why they wanted to be more on a clinical talk. So but it is a very important area of research which is still going on in very parts. And ma'am rightly said that.
Dendritic cell modification.
My question is about that atopic march phenomenon, whether it still holds true or now it is obsolete, the theory is obsolete. Whether it is whether atopic march or there is cluster, is there any evidence or is there any study that might have shown that if you treat atopic say dermatitis early enough, and then how are the chances that in later life they might have also the propensity to develop allergic asthma or the atopic dermatitis or rhinitis, atopic rhinitis, etc. So this is one, because I remember during our childhood also people used to say, okay, that if somebody is having eczema, don't treat that, because if you treat eczema, they may ultimately end up suffering from asthma. So later on we laughed at that and said that all these are nonsense. But then there are also a lot of anecdotal reports, and there are some belief, and to a certain extent it can also be substantiated by that atopic march hypothesis. But what is the current status, and is there any study who have followed up these patients longitudinally to see what is the propensity, if you treat early, whether the chances are less rather than if it is delayed, etc.
So thank you, sir. For the eczema or dermatitis part, there is more skin breakage. So in one theory and in several studies it has been seen, if there is skin breaking, the antigens are coming directly. If suppose any antigen when it is taken through the orally, suppose a peanut, there may be some gastrointestinal different type of cell that will modified by it. So there is less immunogenicity. But when it is exported directly from the skin, there is no modification that cause more allergenicity. So if we prevent the atopic dermatitis and we take care of the skin, the barrier function is maintaining, so there may be less chance. Okay, and in several studies, because there are a lot of studies going on, and so they are showing differently. Some studies showing there is linear correlation, some studies showing there is clustering, but usually it has been seen due to their different systems in their different presentation. So we can't say exactly what will happen afterward. Certain we can predict, but not exactly we can say at this moment. Thank you, sir.
I think from on the morning we were discussing about this atopic march. Now the terminology shifted to atopic march to atopic dance, and I think in our that recent book we had published with, under the guidance of Professor Shoibal Moitro sir on allergy practice, we had categorically mentioned in one subchapter why this shift is important from atopic march to atopic dance, because it is not just following one specific sequence only. There could be lots of overlap, as you also had mentioned.
The shift from the march to dance is basically the longitudinality is questioned. Instead of progressive decline or progressive increase in the propensity, probably if there are these allergen or response to the allergen is concerned, instead of gradual increment in the propensity of developing allergic other allergic diseases, that has been questioned, and instead of that there is a possibility that it continues throughout the life if you temporarily follow up. That's what I could understand.
So now we have a very good paper on this, which is called the area medal hypothesis. Medal is the mechanism of development of allergy. This was there in the allergy last year, and there they have shown that this is a medal hypothesis. What we talk about the linear progression of a disease from atopic dermatitis to the food allergy to asthma and the rhinitis, that usually takes place in a small subset of the patients, but actually it all depends upon the route of entry of the allergens and the patient's entire way in which the child is developing. And in that way, a very important factor which is now being played is the various environment in which the child is having, in the urban area or the rural area or the semi-urban areas, and the various particulate matters in the environment, PM 2.5, PM5, the ground level ozones, the oxides of nitrogen, the sulfur.
Including exposure to infections.
Including exposure to infections and also the exposure to the antibiotics. So that is the way in which it has come out to be understanding more and more that initially which is more of a linear pathway seen only in the few, but it's a systemic disease. Now we say allergy is basically a systemic disease with the manifestation of one organ and another occurring sequentially or together. So everything depends upon the homing of the cells and the triggering agent which is going to that particular organ, the pathway. So that's how the manifestation takes place. So that is how the concept has changed nowadays.
So if we don't have any more question, it is time to felicitation, and it is a real honor for us to felicitate our respected speakers. So now may I ask Dr. Saurabh Dash and Dr. Atrey Rai Chaudhary to kindly felicitate Professor Shoibal Moitro. Also, may I ask Dr. Saurabh Das to kindly felicitate Professor Sudip Ghosh. Sir. Also, may I request Dr. Atrey Rai Chaudhary to kindly felicitate Dr. Kollul Pal. May I request our past president, Professor Shantanu Kumar Tripathi, to kindly come and please present the mementos to our respected chairpersons, Dr. Saurabh Das and Dr. Atrey Rai Chaudhary. Also Dr. Saurabh Das. So we'll have one So now we are at the end of our program, but this is a very important topic. We will be talking about clinical research ethics, and as it is an allergy asthma research center, so research ethics is an integral part. So for this session, may I invite Professor Partho Sarkar to chair the session. Professor Partho Sarkar, currently the chairman of Association of Physicians of India, West Bengal branch, and sir is Professor of Department of Medicine at KPC Medical College. So welcome, sir. Sir is a very renowned clinician and researcher of this state. Also, we have with us since morning Professor Ena Ray Banerjee. So, madam, I am also requesting
and lot of papers presented. I don't have the details with me right now. That's a big one. So I think he needs no further introduction in this fraternity. So without wasting any further time, I will request, sir, that the podium is yours. You can start your deliberation. Thank you.
Thank you for the introduction. And I am sorry that I was not present through the whole day, but I am sure there have been very rich deliberations. Although the size of the audience is scant at this moment, but then this is quality audience. I'm trying to be brief. I'm sure since morning, whatever has been discussed, the body of knowledge today in the area or the areas that have been discussed, all have been derived through a systematic search or systematic investigation. And that's what is research. As doctors, when you are practicing medicine, we are actually depending on the existing body of knowledge that has been accumulated through research over many, many years, many decades. Okay? So research is indispensable in medical practice. At the same time, we must be able to distinguish between practice and research, although some research is also embedded in practice. Why it is important to distinguish research from practice? Because no patient, when he is coming to you, you are the doctor, is coming to you to take part in research. A patient would come to you when the patient feels that he is in need of healthcare. He has some issues so far as his health is concerned, and he is seeking care, and he comes to you. You are the doctor. Now, you are the doctor, but at the same time, you also try to play another role, and that the second role is that of a researcher. So you are donning the second hat, although many a times the patient will not be knowing that you are not just a physician to that doctor, to that patient, but you are also a researcher or an investigator. So this is a dilemma, or this is the physician, the doctor, should very carefully try to handle that. Because it is here where this conflict, okay? If we cannot handle this conflict well, then who is at the receiving end? It is the patient. Patient is vulnerable. When I mention about vulnerability means, simply put, that if I don't have an authority to say no, that means I am vulnerable. That means I'm not allowed to take or exercise my right to determine what I need, what I want, or what I agree, etc. So that is what is called compromised autonomy. Autonomy, the term autonomy comes from autos and nomos, self-governing, self-decision making, respect for self. So when I am doing research, I am a physician, and then I am interested in research, and all physicians should do research, otherwise medicine is not static, medicine is a discipline. So medicine cannot be without research. Research is indispensable, but then no research can happen without participation by the patients or human beings, not necessarily always patients, healthy human beings, they have to take part in research. Health research, biomedical research, clinical research, we need people to join, people to participate. And then all such research needs to be properly monitored, properly regulated, properly conducted. When I say properly, I actually mean ethically. So as a researcher, I'm interested in generating data, capturing data, and then processing them, and then analyzing them, coming to a conclusion, and then applying that conclusion into practice. That is what is intended of research. Purpose of research is only that, translating new knowledge, generating new knowledge, and translating them into practice for the welfare of the human race, for that matter, when we talk of clinical research. But while engaging myself into this research, I should be conscious that the people who are participating, their rights, their well-being, their respect for self must not be compromised. And who is the best person to ensure that? None other than the physician, to whom the patient has come and seeking care. So this is what is ethical approach towards conducting clinical research or human research. Now this is a field, allergy, which is otherwise a vast area. Since morning we must have heard, the last session also when we heard, we could appreciate that age is no bar when you talk of allergic disorders. Okay? It can occur in all ages, and it can also occur because it is toying with our inherent ability to resist, okay, any infection, any outwardly assault or insult, and that is what is our immunity. So that is being otherwise very much dysregulated, and that's the reason why I am being allergic. Allergy is nothing more, nothing less than that. So thereby, anybody, so long we are alive, we are also blessed with our immune system, but sometimes this also will behave in a very peculiar manner. And so, simply put, that is the basis of the allergy and allergic disorders. And any new knowledge in the area of how to handle allergic disorders has to come through research. Now when we talk of allergic diagnostics and therapeutics in any area, if we try to answer these few questions, any therapy or any diagnostic test, who recommends it? And on what basis it has been recommended? Has it been otherwise enough studied? Has it been otherwise studied scientifically? That is, has it been researched on? Have the evidence been generated through, as I have said, what is research? It is a systematic, pre-planned, okay, well-purposed investigation. Purposive, well-planned, and systematic investigation in order to answer a carefully framed research question. And finally, the final aim is actually, final goal is actually to help the mankind. That is, we have to translate that. If the translational component is not there, whatever research I do, I just publish and forget it, then possibly this will not, we are not doing justice. Because all research is extensively resource intensive. So we cannot afford to misuse this scarce resource. So these are the few questions. If evidence has been generated, how it has been generated, and the evidence, does it work? Does the evidence, is there evidence that it works? The strength and the quality of such evidence? What are the risks versus benefits when you are using this, trying to translate this? How does it impact on the quality of life of the patient? We are gaining, might be relieving the symptoms, but at what cost? How much does it cost altogether, financially? Would it be covered by insurance? Insurance, you must remember, maybe up till now we are in a relatively advantageous position, but then our society, but maybe in another decade or so, we will have more stringent insurance decisions, that any intervention, any treatment intervention, if it is not based on hard evidence, the insurance company may not agree to provide your support. So these are broadly two types of clinical research in India, regulatory research which are mainly for development of newer treatments, newer drugs, newer diagnostics, devices, and academic research. So whereby investigator initiated research, the other name for academic research, that is also equally important for effectiveness trials, for prolonged safety surveillance studies, etc., etc., and also the basic research. Clinical allergy research, basically broadly these are the three domains, organ system domains or otherwise morbidity domains, airways, skin, food allergy. There is certainly unmet research needs. Broadly two types of research we know, that observational type and the experimental type. Experimental research, simply we say that it is clinical trials, but then there are observational research, again depending on the nature and direction and the time, temporality. So observational research again is divided into three broad types: cross-sectional research, point of time, and then longitudinal one. Two types again, forward-looking, that is cohort, and the retrospective, backward-looking, that is retrospective studies, that is also called case control studies, when you are comparing two arms. Research on allergen-specific treatment, that is oral immunotherapy, sublingual immunotherapy, and epicutaneous immunotherapy, which is nothing but pads, where slowly it will be released. And allergen non-specific treatments like anti-IgE drugs or probiotics, etc., they are also coming up. CAR T-cell therapy, which has proven efficacy in cancer, but CAR T-cell therapy, its application in allergic disorders are also coming up. Practice research, registry-based effectiveness study, real-world evidence studies, case study, case series, translational research, outcomes research, where endpoints like clinical endpoints, economic endpoints, humanistic endpoints are considered, and of course qualitative research, which otherwise we are not very comfortable with in clinical research, but qualitative research has its own value. Before I go further, I think we also have to make a clear distinction between what is observational research and what is clinical trial or experimental research by just one question, asking one question, that is, did the investigator assign the exposure? If it is yes, then it becomes clinical trial. If it is no, then it becomes observational study. Many a times we find, sitting in the ethics committee, there is a lot of confusion. I am not going into further detail, we have just discussed. And we must know also the difference between the analytical study vis-a-vis the descriptive study. Clinical trials are always analytical, but observational study could be either analytical or descriptive. When there is a comparison group, it is usually analytical. If it is a single arm, you are just based on descriptive statistics, that is a descriptive study. This is to talk about the different unmet needs in the area of different kinds of allergic disorders. Like this one describes the unmet needs in allergic rhinitis, the International Survey on Management of Allergic Rhinitis by Physicians and Patients. The optimal management is the SMART 2 study in 2015. This is again current research and unmet needs in allergy and immunology in Germany, a report presented by DGFI, etc. So there is always the paucity of ethical analysis in allergology is there. This is again, this is 2013, a little old. Disease burden and unmet need for acute allergic reactions, the patient perspective. So this is again 2024, very recent one. So this unmet need is a big issue. Treatment for food allergy, current status and unmet needs. We also, when we talk of research, we must also be reminding ourselves of the evidence pyramid. We all know that clinical trial is still now considered as RCT, randomized controlled trials, are considered as the gold standard for generating evidence. But again, if there are multiple clinical trials trying to answer the same question and then have published their analysis reports, we find there is some kind of discordance, then we think of, because we need to develop our treatment guidelines, we think of synthesizing this data. Meta-analysis means analysis of analysis, many analyses, and this becomes a secondary research, and that's what we call meta-analysis and systematic review at the top. But in the middle you see that randomized control trials. Later than, inferior than that is observation studies, cohort study or case control studies. Of course, all of them are actually association studies between the exposure and the outcome. And if you go still below, that is case report or case series, So they are not really considered as hardcore research, case report and case studies, but also by definition they are also put under research, because when you try to publish it again, they will ask for ethics approval, etc., etc. And then there are also subhuman studies, animal studies, laboratory studies, etc. So as you go up toward the apex of the pyramid, we find that gradually we are having stronger evidence for the to be generated. Then again, you have to also grade the quality of evidence and the strength of recommendation in clinical practice guidelines. We also know of the grade criteria. So where it is not just enough to create the evidence, but you have to also grade the strength and quality of the evidence. Coming to the ethics in research, this is the principles, ethics principles: respect for autonomy, non-maleficence, beneficence, and justice. And we have mentioned about respect for autonomy. The second one is non-maleficence, that do no harm. It is true both in practice and research, that we must see when we are engaging ourselves into research, that all people who are taking part in research, we must see that they are not harmed at least. And we should also always intend that they are benefited somehow. Although we must remember, the primary purpose of research is not providing benefit to the patient. It is benefit for the future patients or the benefit for the society. When you talk of justice, we actually mean fairness in treatment. That is what is justice. But then, while considering these four, sometimes they might be in conflict, which is otherwise, and there you have to take a decision, which one is to be given more weightage. And this is the respect for autonomy part. Any notion of moral decision making assumes the rational agents are involved in making informed and voluntary decisions. It's a negative obligation not to interfere in choice, and as a positive obligation to provide appropriate information, so informed decision is made. In fact, this is achieved through informed consent. When you say informed consent, we actually mean that informed, voluntary, understood consent. This voluntary and understood part is actually missing in this informed consent phrase. But then we must remember, it's not just a form, it is a process. Informed consent process, we need to engage ourselves appropriately. Non-maleficence, doing no harm, thwarting or defeating somebody's interest. It is a negative duty or obligation of research ethics, pollution, environment, etc. Beneficence, taking positive steps to prevent harm or remove harm from the patient. Actively promote well-being of that patient who is participating. It's a positive duty. Justice is all persons treated equally or equitably. Aristotle had said, giving to each that which is his due. Fairness is to be practiced, and distributive justice, who gets treatment when there is shortage, etc. And here you see the hierarchy of the principles of ethics. When you talk of research, autonomy is topping the list. Then comes beneficence and non-beneficence, and finally justice and quality. But when you talk of practice, medical practice, it is the beneficence and non-maleficence that is taking upper hand, and then of course autonomy and justice and quality. Comes to teaching, justice and equality is at the top, beneficence and non-maleficence then, and rest is autonomy. Meaning thereby, if a student says that no, I am not ready to attend your class, so we don't allow them, because they are not in a position to really appreciate what is good or not so good. So there probably that's why we are keeping that at the lowest level. Although students or learners also have the right to decide for themselves, that is also accepted in different parts of the law. These are some of the very important documents, ICMR guidelines for both pediatric research and otherwise general thing. There is a handbook also in between that document, which is a simplified form of all the sections that has been discussed in these two books. So all of us who are otherwise serious about conducting research, human research, clinical research in any field, including in allergy, we should go through this. These are the guidelines. This is the handbook 2018, which covers in 12 chapters. Responsible conduct of research has been very much emphasized through these guidelines. And today, let me share with you, in India, conducting research, it is, on one hand, it is a social obligation. On the other hand, it is heavily regulated. So one should be serious about it when we are conducting research. Otherwise, it could also be breach of regulation. Informed consent process. we just mentioned, but we have to also remember that we have to decide whether the person whom I am seeking consent, whether he is competent to give consent. Like very young child might not be competent, or somebody with a compromised mental function might not be competent. In that case, you have to think of proxy consent or somebody else surrogate consent, etc. is to be considered. Biological materials, biobanking and data sets in research, that also very clear guidelines are now available, and time permitting we can discuss on that. These are the different stakeholders in research. If we think of the regulatory or academic, the different stakeholders are, of course, most important is patient or the human beings at the center, but then closest to them is the doctor come investigator, researcher, and then the ethics committee, local ethics committee, institution ethics committee, because they are supposed to look after the interest of the research participants. And then if it is regulatory, then of course the drug regulator of India. Besides that, in case of regulatory clinical trial, which is responsible for getting new drugs in the market, so they are the industry sponsor, they are also very important stakeholder. But otherwise, when you talk of academic, there it is the investigator himself plays dual roles again, one as a researcher, investigator, and the other as sponsor. Who is a sponsor? Anybody who conceives an idea and writes the protocol is a sponsor. Many of us have a mistaken belief that anybody who gives money to conduct the research is the sponsor. No. The person who develops the protocol is the sponsor. So, in investigator-initiated study, the investigator himself is the sponsor. So, that is again, in our country, we do not have a guideline yet to actually govern investigator-initiated study, which is right now being developed. Maybe in another 3-4 months, it will be published by ASTHMA. Coming to this, a few slides more. Shared genetic architecture between gastroesophageal reflux, asthma, and allergic disorders. So there is also genomics getting into it. So there are different aspects of ethics will complicate things. Unmet needs in children with peanut allergy, aligning the risks with the evidence. So these will give us some of the idea about, if we are interested, what areas we should talk to. One part of this title is innovations, that these are the areas where we can put our attention to. This is a peanut oral immunotherapy trial for people over 16 years. So worldwide this is happening, and then this link has been given, I think, from this society also. If you are interested, you can click. This is still active. This research group, they are asking for collaboration also. So this can help. I think as a body, this institution, this organization, it can think of having more and more collaborative investigator-initiated studies. So I think that also makes sense. CAR T cells for treating severe atopic allergy disease, it has come in. That is a different question right at this moment. How many of us would be able to actually afford CAR T cell therapy? But as we know, in India also, there has been a lot of government support, and I think IIT Mumbai, they have come up with this CAR T cell therapy, indigenous CAR T cell therapy, which has made the cost of CAR T cell therapy very, very low as compared to what is there in the Western world. Choice, this is another study, choice allergen immunotherapy study, that is criteria used by health professionals on the selection of allergen immunotherapy in real clinical practice and international e-survey. This is also active now, so if some of you are interested, you can think of joining this. Click this and submit. So that is a very good opportunity to be in the international map for doing this kind of studies. Center for Allergy Research. Okay, this is in Karolinska Institute, and I draw your attention to the last paragraph, that this involves the disciplines like not just allergology, molecular biology, biochemistry, epidemiology, biostatistics, physiology, pharmacology, immunology, environmental medicine, etc., genetics, and whatnot. So when you talk of allergy research, it's a huge comprehensive world really. You cannot think of just clinical allergy and then treating that and how to get a new medicine. Unless we get a network of multidisciplinary effort, so probably we'll be missing the target. So thank you very much.
Professor Tripathi, such a beautiful lecture, and I really wish my students were here. The empty hall really is very sad, and I really wish my students could listen into your lecture. Not only is it necessary in clinical practice and basic research, but the way we conduct ourselves, I think a lot of this, especially because we are in the post-truth era, so truth, the real truth and nothing but the truth, absolutely must be withheld. So in your excellent talk, you have outlined all that and more. So thank you very much for that excellent talk. Shall we have questions from the audience? বিজয়, তুই ট্রান্সলেশনাল রিসার্চ করিস, স্যারের বক্তৃতা শুনতে পেয়েছিস, যদি কোনো প্রশ্ন থাকে। Oh, I just wish that we have more collaborations. We need to connect those dots and we need to come up with something viable rather than being islands of excellence. Thank you so much.
I look forward to another opportunity where more detailed discussion can take place. Instead of a didactic lecture than this, like this, we can have a discussion forum rather with your students or wherever. Thank you.
Absolutely.
Thank you, sir. So, may I request Professor Partho Sarkar and Professor Ina Roy Banerjee to kindly felicitate Professor Shantanu Kumar Tripathi, sir. Also, may I invite Professor Shoibal Moitro, sir, to kindly felicitate Professor Ina Roy Banerjee and Professor Partho Sarkar.
হ্যাঁ হ্যাঁ
Now I think we have Dr. Bijoy, because as you were the only presenter today, we want to felicitate you. So please come on the dais, and may I request Professor Shantanu Kumar Tripathi sir to kindly felicitate Dr. Bijoy. You have done a very good research work. So also, madam, please join. I think we are very small crowd now. This is a thanking address, but I think we can have a group photo. I request all of you who are present there, please come on the dais. We'll take one group photo and to end the session. So make sure, please come. Monishadi, please come, and please call if Jyotirmoyda is there. Okay. I am requesting all the other who are waiting outside, please come inside. We'll have a group photo. সন্দীপদা চলে এসো। Please come. Those who are sitting, please come and join us.
এখন কি ছবি উঠবে?
হ্যাঁ, একটা গ্রুপ ফটো হবে।
এই গ্রুপটা একটু দরকার দাদা।
সানিজিৎ, জ্যোতির্ময় কোথায়?
স্যার একবার ছবি
আর একটু মধ্যিখানে চলে আসুন, একটু এই পাশটায় চলে আসুন সেন্টারে। হ্যাঁ ঠিক আছে।
এটা কার মোবাইলে তোলা হচ্ছে?
বুঝেছেন?
কাটলাম।
ব্যাগটা তো আমার, ব্যাগটা আমার কাকতলায়, এটা আমার।